So we are live now.
Good afternoon, everyone. Welcome back to MetaSearch 2021 and OBENCON. Um, we have more interesting session today and even tomorrow. We have many renowned Indian endocrinologists and two world-renowned foreign faculties, and we are excited to listen to them. The first presentation is from Dr. Harshal Ikatpure, and our moderator is a senior physician and our friend Dr. Vasudha Sardesai. Thank you, Dr. Vasudha, for joining. I would request her to introduce the speaker, and then we'll start with first presentation from Dr. Harshal. Dr. Vasudha, please.
Yes. Okay. Good afternoon, everybody. I welcome you all for this afternoon session of our conference, and I congratulate Dr. Shashank Shah for taking initiative in such an important topic of life, that is obesity. And now we are going to listen to Dr. Harshal Ikatpure. He is a consultant endocrinologist, Ruby Hall Clinic, Pune. He is one of the rising stars in endocrinology field of Pune. There are several posters and oral presentations in national and regional conferences from Harshal Ikatpure. And today he is going to talk on use of fiber in weight loss. So dietary fiber, the importance of dietary fibers, we are going to listen to today from Dr. Harshal Ikatpure. Sir, please, you start your lecture.
Yeah, so good evening all. Myself Dr. Harshal Ekatpure. I'm consultant endocrinologist at Ruby Hall Clinic, Pune. Today we will be discussing little offbeat topic, that is the role of dietary fibers in weight loss. And let me start by defining the dietary fiber. That the term we heard very often, but we don't know what it is actually. So in a common language, we call it as a roughage, and it comprises the group of substances in a plant food. So it is always obtained by a vegetarian sources, and it is lacking in the non-veg sources. And these are actually the cell walls or the components of the cell wall, which are not exactly or completely broken by the digestive enzymes which are present in our system. So humans are not able to digest it, and that's why they remain undigested, and that is why it is called as a roughage or a dietary fibers. The typical example is, of course, cellulose, which is abundant, one of the abundant dietary fibers, and another one is pectin. So what are the sources of these dietary fibers? Because different type of food items contains different concentration of dietary fibers or different quantities of dietary fibers. And nowadays, as our diet has been becoming more and more refined, we are using more packaged food or more processed food, the content of dietary fiber is becoming less day by day. So the whole grains, when we talk of the whole grains, particularly the wheat bran, मराठीमध्ये ज्याला कोंडा म्हणतात, the wheat bran is a good example of a dietary fiber. So whole grain cereals, they contain the dietary fibers. Lots of fresh vegetables like cabbage, cauliflower, and if you are particularly rich, then you can have lettuce. These are all very rich source of dietary fibers. Fruits, particularly the fruits which are not very sweet, like guava, oranges, mosambi, they are very rich sources of dietary fibers. Some nuts, and of course the beans, the rajma, soya beans, sprouts, and lentils. These are some examples of the dietary fibers. So as you can see these examples, and you can compare your daily dietary intake of these fibers, you can see after it is, you can see that the dietary content of our dietary fibers is very less. So these different dietary fibers have a different functions in our body. Of course, it helps prevents the constipation, reduces the risk of diverticulitis in long run. It helps to maintain the blood cholesterol levels, help to control the blood glucose level to some extent, and of course the feeling of satiety that occurs with these dietary fibers. Now, actually, how much dietary fibers we all need? In an adult, particularly a grown adult, the actual requirement is a 30 gram per day. And to satisfy that need, the need of 30 gram per day, we need to consume a good amount of veggies or good amount of foods to satisfy that need. But we are lacking behind. because on an average, the dietary intake of this fibers is somewhere around 15 to 18 grams only in adults. Similarly, in children, those who are told 2 to 5 years old, 15 gram per day, 5 to 11 years, 20 gram, 11 to 16, 25, and after 16, it is more or less adult type requirement, that is 30 gram per day. So this was actually about the dietary fibers in brief and what is the total daily requirement. But how they actually help you in terms of weight loss, there are 2, 3 mechanisms by which they can help. First and foremost is the dietary fibers. They have a capacity to absorb water. They will retain water. So whenever you consume the fibers, they will retain water and they swell up inside your GI tract or inside your stomach. So they will remain in your stomach for a longer period of time. It will slow down the gastric emptying. The movement of the stomach will slow down. So once your stomach movement slows down, you feel full for a longer period of time. So the fullness or amount of satiety, increased satiety is there with the increased consumption of these dietary fibers. And that's why you feel less hungry. So that's why frequent munching in between the 2 meals that gets reduced and your caloric intake gets reduced. So this is the one mechanism by which there is a reduction in the caloric intake, a prolonged feeling of satiety, and helps you losing weight. Second thing is they improve the glucose tolerance. Now, what do you understand by glucose tolerance is that when we consume a meal, it contains some amount of carbohydrates, some of which are refined carbohydrates. And refined carbohydrates are like your bread or pasta or noodles or anything that contains maida, that is called as a refined carbohydrate. So these carbohydrates get absorbed immediately. They give rise of blood glucose level, or they give spike of blood glucose levels. And as blood glucose levels spike, it comes down also suddenly, and that causes the typical hunger pangs, because our central hunger mechanism is designed to judge the variation in the glucose level rather than the absolute glucose levels. So when there is a fluctuation in the blood glucose level, person tend to feel more hungry, and that actually produces the hunger pangs. So when you include the dietary fibers in your normal meals, what it prevents is the glycemic variation. It does not allow the glucose level to suddenly go up or suddenly come down. And that glycemic variation is prevented. So there are less hunger pangs and there is less episodes of overeating. So whenever you get hungry, obviously you get a cravings and you tend to eat more, or you tend to eat whatever you get your hands on. So less hunger pangs, less overeating, less caloric intake, and that helps in terms of losing weight in the long run. This is the most important mechanism. The favorable changes in gut flora. Gut flora is a bacterial flora or bacterial colonies that are there inside our GI tract. Now, every person's bacterial flora is unique for that person. It depends on the exposure to the different food stuff while you are growing up. So when every person's gut flora is unique, the harvesting of the nutrient of every person is unique, because you can see some people eat lots of food, still they don't put on weight. Some people even eat half of whatever normal person eats, still they are putting on more weight. So one mechanism behind that is gut flora. Suppose your gut flora is such a way that it is harvesting more energy or taking more nutrients or more calorie rich food from the gut, that can lead to the more weight gain. So by taking a high fiber diet, what happens is that more gut friendly flora, you can say it as a gut friendly flora, that colonizes your GI tract. And whenever this gut friendly flora colonizes your GI tract, there is a less energy harvesting. So the energy consumption or the energy generation from the food gets reduced by changing in the gut flora. And there has been studies with this, the different types of gut floras and different types of energy harvesting done by these gut floras. So there is a favorable change in the gut flora, which leads to the less energy harvesting, and that's why there is a less chances of obesity. And of course, the calorie content of the meal. Like we all know that major way to reduce the weight is portion control. Once you lose the weight, maintenance of weight is another challenge, and for that also portion control helps. Now, what do you understand by decreasing total calorie content of the meal? Is that you have to replace the simple carbs with the complex carbs, because complex carbs will contain more amount of dietary fibers, and they not only reduce the glycemic load but also helpful in reducing the early and prolonged satiety. Now, satiety we have already seen. Now, let me give you an example here. So, if you are consuming 2 slices of bread for a breakfast, you can replace that with a either ragi ka bhakri or bajre ka bhakri. Ragi is nachni, that's what we call in Marathi. So when you replace the white bread is a processed food, it contains only maida, that is simple carbs, no dietary fiber. And when you replace it with the ragi or bajra bhakri, it will contain the carbohydrates also, but it will be complex carbs, there will be dietary fibers. So it will lead to the lesser spikes and you feel full with a shorter portion of the meal or a less portion of the meal, and you feel full for a longer duration of the time. So that's how you can reduce the total calorie content of your meal by replacing the simple carbs with the complex carbs. So these are actually the 4 mechanisms which are responsible for the weight loss in a longer run by use of dietary fibers in adequate amount with each meal. There are definitely other benefits also with the dietary fibers. Of course, it prevents constipation. Now, very 1 in 3rd person, that is 33% people nowadays suffer from a constipation because of dietary changes and lifestyle changes. So to that aspect, it helps. Eliminates the bacterial toxins. Sometimes whenever there is a colonization of a GI tract by unfavorable bacteria or pathological bacteria, those toxins gets reduced by the use of dietary fibers. Reduce risk of GI cancer. This is proven fact that patients who consume processed meat or processed food, they are more prone to develop the GI cancer like colon and rectum. And the patients who tend to include the dietary fibers more in their diet or natural fibers more in their diet, they have been protected with colon cancer and the rectum cancer. So reduce risk of GI cancer, that is huge advantage. And then again, the favorable effect on a lipid profile, because the enterohepatic circulation of the cholesterol is affected by the consumption of the dietary fibers. So your total cholesterol levels and to some extent triglyceride level also comes down with the use of dietary fibers. And in long run, it helps in weight maintenance. Like you must have seen that achieving the weight loss is one thing, maintaining the weight is an entirely different ballgame, because most of the people rebound after they achieve certain weight loss. So for maintenance of the weight, of course, the dietary fibers help, like the mechanisms we have discussed before. With that, the dietary fibers help you maintain the weight which you have lost. At the same time, if you are maintaining the weight loss, in the long run, it helps to reduce the risk of diabetes also. So, what are the ways that you can increase the fiber in your diet? Of course, there are fiber supplements which are available that you can take over and above. But always, when there is a plate in front of you, always think that how much fibers I am having in this plate, and always do these simple tricks to increase the dietary fibers in your daily meal. So, with each meal, at least there should be some amount of dietary fibers that should go into your system. So, in a meal or in a breakfast, try to make a healthier choices like whole grain breakfast cereals. Whole grain contains more fibers. Avoid breads, bakery products, maida products for any meal per se, and replace it with the complex carb like I mentioned, the bhakri or chapati for that matter. Oats, fruits or vegetables that you can add with each of your meal. Like breakfast, you can add oats. With lunch, you can take fruits and more veggies at the dinner time. That's how you can satisfy the dietary fiber need. Salad, side dish of salad is must with each and every meal, like cucumber, carrots, and other salads. And beans and pulses. The consumption of the fresh beans and pulses in between 2 meals, that actually is a good way to have your snacks. More beans and pulses between the 2 meals is a ideal way to have more snack and more dietary fibers. So to summarize, our regular or recommended dietary allowance is 30 grams per day for dietary fibers. Many people have less than that intake. Low fiber intake, like we have seen, associated with constipation and gut disorders. And when you optimize your fiber intake, you don't want high fiber diet, but when you optimize it, that at least you take 30 grams per day, that actually helps not only in terms of weight management, but in the long run, it helps to reduce cholesterol, the risk of diabetes, and gastrointestinal cancers also. So what I feel is that dietary fibers is one of the most neglected part of nutrition therapy, especially in the obese patients, and it definitely has a therapeutic value whenever you think of weight loss. So along with the high protein diet, high fiber diet would also be helpful in terms of reducing and maintaining the weight loss in these patients. So with this, I thank you all, and if at all any questions, I would be more than happy to answer them. Thank you.
Thank you. Thank you, Dr. Harshal. If there are any questions,
Dr. Harshal,
if there are any questions, please ask about fiber in dietary fibers, role of dietary fibers in obesity.
thank you, Dr. Harshal. Let me ask you one question. So many people are unable to consume adequate amount of fiber. Let me just take a second. Sir, thank you for joining. Dr. D. Fronzo is here very early in the morning. It's a pleasure and honor for us to have you here, sir. Dr. Harshad, so the question is, in case the person is unable to take enough the fiber orally, do you recommend supplements, fiber in the form of supplements to complete the daily requirement?
Yeah, because now most of the people working away from the home or living away from the home, and that's why it is not always possible to include the necessary amount of fibers. So the fiber supplements is actually need of the hour, and the multiple formulations with different types of dietary fibers should come in the market to satisfy the needs of these people actually who work in IT sector, or those who work from 9 to 9 job. So it is very difficult for these patients to go out and actually procure the stuff which is rich in the fibers. So ideally, I supplement these patients with the dietary fibers, especially at the dinner time. And I always advise them to consume it before meal, so that their portion of other nutrient content also gets reduced and they feel full for a longer period of time.
Dr. Harshal, I have one question for you. That is there any difference of between the role of soluble fibers and non-soluble fibers in our with respect to glycemic index and with respect to the caloric requirement?
Yeah, so I think the insoluble fibers, as far as the soluble and insoluble contents, insoluble fibers are much more effective in terms of retaining the water. Soluble fibers more or less form a gel-like substance inside a GI tract. Insoluble fibers not only retain the water, the gastric emptying is more slower when you consume the insoluble fibers. So that's why the glycemic variation and glycemic excursions are much less with insoluble fibers. So that's why I always suggest using the insoluble ones for weight loss or even for a glycemic management per se.
Okay.
Thank you. We have Dr. Tejal also who has joined. Thank you, Dr. Harshal. Well covered topic, and I hope that this will benefit all those who are joined. Thank you so much.
Thank you. Thank you. Thank you, sir.
Thank you, Dr. Vasudha, for joining us and accepting the invitation. Hardik, can we have the next presentation? We have a very senior physician and diabetologist and our friend Dr. Harshay, sir, who has joined us. May I request Dr. Harshay to introduce Dr. Tejal Nathia, who is actually on the way to the airport, but we have her presentation and she is joining us. Dr. Harshay, please.
So good afternoon, everybody. First of all, I thank you, Dr. Shashank and his team, to inviting me to have an opportunity as a chairperson to his great and timely needed session. Friends, you know that obesity is a major challenge and a major risk factor for metabolic disorders as well as cancers. And to reduce weight is also a challenge. Not only that, the maintenance of weight reduction or maintenance of proper weight is again a major challenge. So are there any factors which are predictors for the maintenance, long-term maintenance of weight reduction, or are to be assessed before implementation of weight loss program or after the weight loss program? is a concern nowadays, obesity management. So for this important aspect, we have Dr. Tejal Lathia, a gold medalist specialist in endocrinology and hormonal diseases, and have been practicing since last 10 years in treating patients in top hospitals in Navi Mumbai, Fortis Hiranandi Hospital, Vashi, Apollo Hospital, Belapur, and Cloud9 Maternal Child Care Hospital. She has two book chapters, Bariatric Surgery, Orja, and she is convener of Wellness and Women Health and Women's Voice, and convener of Endocrine Across the Lifespan. She is a co-designer of HEAL PCOS program, and her major achievements as co-author as launch matters for in type 2 diabetes in India. So over to Dr. Tejal Lathia.
So at the outset, I would like to thank the organizers, especially Dr. Shashank Shah and his team, for the kind invitation to this conference. This is the first time that I am part of a conference which is exclusively, organized by a bariatric surgeon. I have a lot of friends in the fraternity, and I personally believe a lot in bariatric surgery. However, the topic which I have is something that as an endocrinologist I deal with in the clinic, and that is medical weight loss. So good evening, everyone, and I'm going to speak about the predictors for long-term success of medical weight loss. I'm a consultant endocrinologist practicing in Navi Mumbai, and my agenda for today is briefly divided into two sections. One is what is medical weight loss, what does it include, and what are the predictors of weight loss. Unfortunately, our options for medical weight loss are very limited. So they can be divided into nutritional modifications, exercise-mediated weight loss, or a combination of both of these. Use of approved medications like Orlistat. All the other medications have now been taken off the market, which includes rimonabant, sibutramine. All of them have been taken off the market. These are drugs that we do use, liraglutide or topiramate, but these are not approved exclusively for weight loss, at least in India as of yet. So as you can see that the options for medical weight loss are largely restricted to lifestyle modifications, which include diet and exercise. Now today I am not going to go into any of the details of either nutritional modifications or exercise mediated weight loss, because what I think is that any particular diet or any particular exercise regimen, if done consistently and persistently, will result in some kind of weight loss. But what we are interested here is that which of these interventions is successful in the long term. So maybe 10 years down the line, 20 years down the line, what are the factors which help us to predict that this person is going to be able to not only lose weight now, but maintain this weight loss for the years to come. So this is a beautiful article which was published in 2005. I specifically chose this article as the base of my talk because the authors are also the main founders of what is called as the National Weight Control Registry, which has been following patients who have attained weight loss for close to about 2 decades now, I mean almost 15-20 years, and they've been regularly publishing updates onto what are the factors which they find predict long-term weight loss maintenance. So this was published in 2005, and some of the later literature will also include newer studies. So first of all, let's be very clear. What do we mean by weight loss maintenance? So weight loss maintenance has been defined by Wing et al. As intentional weight loss of at least 10%, which is maintained for at least a year. Now, the reason that the figure of 10% was selected is because it usually, what we all agree, is about 10% of weight loss is necessary to make a meaningful difference in the risk of diabetes or cardiovascular disease, and that short-term weight loss plans can be effective, but maintaining weight beyond a year would mean that whatever has been done has been successful and will be persistent. Now, how many people actually do maintain long-term weight loss? So this is a survey which was done by McGuire et al., where they've included patients who've tried to lose weight by multiple methods. So we're not talking about any particular diet or exercise pattern here. Patients could have done anything to lose the weight. And what they find is up to 20% of overweight individuals are successful weight losers. That means 20% of all overweight individuals who attempt to lose weight will be able to lose at least 10 10% or more of their body weight and will be able to maintain this weight loss for at least a year or more. So this is the weight control registry that I was talking about, which has almost 4,000 participants. The average age of these participants is about 46, 47 years, 77% of whom are women. And the minimum weight loss achieved by people in this registry is about 13.6 kilos, with of course many people having lost more and maintained it. Now, what was the initial result? So the initial result shows that weight loss can be maintained if a low calorie and low fat diet is followed. Now, low fat diet specifically meant that these people did not frequent fast food joints and ate out less than about 2 times a week and had fast food less than once a week. So low calorie, low fat diet, which usually was a diet of approximately 13 to 1400 kilocalories per day. All the patients had high levels of physical activity, and by high levels they mean 1 hour per day of moderate aerobic activity. So now, as endocrinologists, whenever we talk about exercise, the ADA recommends 30 minutes of exercise for 5 days a week. However, for successful weight loss, this amount is too little. It's good for maintenance of maybe glycemic level in patients with diabetes, but for weight loss, more is required. So high levels of physical activity, 1 hour per day or more. Usually this involved brisk walking. So about 70 to 80% of the participants did not do gymming, did not do any other exercise, but mainly it was brisk walking. What was also very significant is the participants weighed themselves very frequently. So some participants weighed themselves daily, and the minimum that they did was at least once a week. So being aware of the weight and immediately taking steps when weight crosses a certain number helps to maintain weight loss. And eating breakfast daily. This breakfast usually consisted of either a cereal or fruits in most of the patients. So these are the 4 core principles which predict that these people are likely to maintain weight in the long term. There are other factors which also are important. What is called as cognitive restraint. Cognitive restraint means the ability to stop yourself from overeating. And those people who had lower levels of dietary disinhibition, so they were able to control their eating and did not lose control over eating, were more likely to maintain the weight loss. What was also very interesting is that if the participants who had lost weight behaved as if they had just lost weight recently, that means they continued to follow the 4 principles that are enumerated and continued to do them at an intensity which was almost the same as when they were losing weight, then these people achieved successful weight loss. There was also the impact of losing weight and maintaining it for minimum of 2 years. So what this table shows is that in people who maintain weight loss less than 2 years, they were quite likely to, almost 100% likely to gain at least 2 kilos of weight over the next 1 year. However, by maintaining weight loss beyond 2 years, the chance of weight regain reduced by 50%. So if somebody lost weight and maintained it for more than 2 years, then they reduced their chance of weight regain in the long term by almost 50%. So what it means is if you lose weight and maintain it right up to about 2 years and a little beyond that, then the chances that you will continue to maintain this weight loss are very good. And those who were able to maintain weight loss beyond 5 years had a 70% reduction in the risk of regaining weight. So the weight they lost in the first 2 years and ability to maintain it beyond 2 years was very predictive of long-term weight loss. Now, what about diet? Again, no particular diet has been selected as the one which is most successful, just an overall low calorie and low fat diet. But what was very interesting, so a lot of times when you read prescriptions given by nutritionists, they talk about cheat days, cheat meals. But what this registry finds is that if you allow flexibility in their diet, that means you expose people to high-risk situations where they have a chance to lose control over their eating, then they're more likely to regain the weight and not able to maintain the weight loss. So having no flexibility or little flexibility, no weekend cheat days, cheat meals, and maintaining consistent diet over the week as well as the year. So for example, Diwali cheat week or maybe Christmas cheat week, New Year cheat week, all of these also. So whenever there was flexibility offered and the decorum was not maintained, these people were more likely to regain weight and lose their weight loss maintenance. Now, this is the part where the frequent weighing or daily weighing on a weighing scale comes into play. So in people who check their weight daily, and even at the smallest amount of weight gain, they tend to autocorrect themselves. So even if they prevented small regains in weight, then they were able to avoid the larger relapses. However, if the smaller regains in weight were avoided or ignored, this usually ended up into larger relapses, and this was critical to delay recovery among successful weight loss losers. So identifying small regains and quickly taking care of them will prevent it from degenerating into a larger relapse in the weight. So far we've talked about diet, physical activity, cognitive restraint, ability to have a decorum, and lack of flexibility. What is also very important is that when people have medical triggers, so this is a study which looked at the predictors of weight loss maintenance, and what they found is if somebody had a history of increased glucose at any time in the past, they were 4.5 times more likely than people who do not have a history of increased glucose to maintain their weight loss. Second is that, of course, decreased consumption of fat over the past year also predicted weight loss. But what I'm trying to highlight here is in people who have a medical trigger, this helps to predict long-term weight loss. This medical trigger in this study was increased glucose, but in our day-to-day activities, increased cholesterol, increased blood pressure. So I think a complete evaluation of an overweight or obese person, pinpointing the medical conditions which may have started like pre-diabetes, and then showing this to the patient helps to not only trigger the weight loss, but also helps them to maintain the weight loss in the long term. Now, this was something that I could not resist, and a lot of women who come to me to lose weight, they may not be very overweight or obese. They don't want to lose weight for health reasons, but for mainly appearance reasons. And how does this compare with losing weight for health? So one thing was very clear, that those people who lost weight for health were more likely to maintain weight loss, and those who lost weight for appearance were less likely to maintain the weight loss. What was also very interesting in this slide, what I'm trying to demonstrate, is in those people who are most concerned about their own appearance and how they looked to themselves, they were the ones who actually gained some weight. Those people who were maybe a little bit interested in how they looked, but not so much, they were able to lose weight. However, the people who lost the most amount of weight, which is 6% in this study, were those who were least interested in their physical appearance to themselves of how they looked, but more for health reasons or for others. So that is very important, is what is the motivation to lose weight. This is one other study which I will very briefly discuss, that if there are multiple health behavior recommendations, can we find out what is it in these multiple health behavior recommendations which again predict the long-term adherence to weight management. Basically, it's very, I think, intuitive that in those who did everything, they had the maximum ability to lose weight and were able to maintain the weight over a period of 1 year. Those who responded to nutrition did the nutritional interventions, but not all of the other health behavior recommendations, they managed to maintain weight. Those who maintained physical activity also managed to maintain their weight. However, those who didn't do anything obviously were the least likely to maintain weight. What is very important, what I want to bring out in this particular study, is that either sticking to diet or sticking to physical activity, both of these did have some impact on weight loss maintenance. Meaning thereby that if you do diet and exercise both, great, you have the best chance of weight maintenance. But if you either stick to the diet or you stick to the physical activity, you have an almost equal chance of maintaining the weight loss. What I'm trying to communicate is that we need to individualize for the particular patient what they enjoy or what they respond to or what they're likely to adhere to, and then encourage them to do that. So for those people whom diet maintenance is not that easy, but they like physical activity, then they could be encouraged to continue physical activity. In those who don't enjoy physical activity but find it easier to adhere to diet, then they should be encouraged to adhere to their diet, and maybe the physical activity can be a little easier on these people. So customization of your health management behaviors depending upon the person's choice can help you to decide who is to be guided as to what they have to do and help the patient to maintain weight loss. This is a study which was published in 2017 in Biopsychosocial Medicine. This again underlines about how food disinhibition, so losing control over eating or being addicted to food prior to the weight loss intervention, and a tendency towards this in spite of initial weight loss, usually there will be a resurgence of the weight. So obviously those who lost a larger quantity of weight in the initial period were more likely to maintain their weight. However, if they lost a larger quantity of weight in the initial period, but they had a tendency to food addiction, or they had a tendency towards disinhibition or loss of control over eating, then they were less likely to maintain the weight loss as compared to those who had good control over their eating pattern. What I'm trying to bring out here is a thorough psychological evaluation of any patient who comes to us for weight loss, finding their emotional triggers for eating, finding what is their attitude towards food, how easily they can control food. And this would help us to kind of customize the plan for the patient in a much better manner. So not only is the diet, the physical activity important, but also what is the psychological component, which can be very, very important in helping patients maintain weight loss in the long term. I'll end with this brief study, which is the Portuguese Weight Control Registry, which basically talks about, again, identifying those people who have had weight loss and what were the factors. Now, in this study, for the longest time, I think what I've heard people say is weight loss is 90% diet and 10% exercise. What this study shows is that 80% of participants who lost significant weight and maintained this over a period of the study engaged in levels of activity which were more than 150 minutes per week. Almost 250 per minute per week was the average, and also men tended to accumulate more physical activity minutes than women. This would also kind of again help us to customize the plan for our patients, and men are more likely to engage in more physical activity and can be encouraged to do more of that, while women, if they're less likely to engage in physical activity, could be given a choice of better nutritional modifications. So what were the most frequently reported strategies for weight loss and weight maintenance over and above physical activity? Again, these were simple measures, all of which were statistically significant. Keeping healthy foods at home, consuming vegetables regularly, eating breakfast daily, having higher levels of physical activity, weight self-monitoring, establishing specific goals, reducing the portion size which was used, reducing consumption of carbohydrate, and increasing consumption of protein. So as I'm going through these slides, so weight loss and weight loss maintenance doesn't seem to be rocket science, but there's simple small things that we need to kind of reinforce to our patients. Some of the other factors, and this was very interesting, those people who had a lot of encouragement from family and friends were more likely to lose weight and maintain weight. Also, vitality is a psychological component of vitality is basically something. Sorry. So yeah, so vitality scores at baseline, that is the psychological component of well-being, where a subjective feeling of enthusiasm, vigor, energy, and alertness, if this is there in a person, this predicts that they are more likely to maintain their weight loss. So I will end this presentation by saying that long-term weight maintenance is possible after intensive weight loss. Up to 20% of overweight people are able to lose weight and maintain it. When we say weight loss maintenance, we mean at least 10% of body weight maintained for more than a year. There are lots of factors, both at baseline or during the first few years of weight loss, which are predictive of long-term weight loss. But what I would like to talk about, which I haven't spoken about in the presentation, is that our patients need comprehensive care. So either going only to a nutritionist, going only to a physiotherapist, doing only physical activity or only nutritional modifications will not be sufficient. There has to be a multidisciplinary team approach where a nutritionist, an exercise therapist, a psychologist, an endocrinologist, all of them have to work together to help the patient lose weight. And only then will they be truly successful in both losing weight as well as maintaining their weight loss. Thank you.
Thank you, Tejas. Excellent presentation, and it's eye-opening for the enlighten us about the predictors of weight loss. I have one question for you. In fact, I just wish to ask you. Suppose we are acting not on basal metabolic rate, and a person having low basal metabolic rate, or who are say fat preservers or not fat losers, are they successful enough to develop or maintain the weight loss? That's one question. And secondly, we are talking about a lot of physical activities. And suppose a person weighing 90 kg weight does an heavy exercise, loses his weight up to 70 kg. For maintenance of his weight, he has to do a more exercise as compared to his cohort who is already at the baseline with a 70 kg weight. So these two obstacles are there. So any your views about this?
So first of all, am I audible?
Yes, nicely.
Okay. So first of all, thank you for pointing out that there are people who are fat preservers who do have a lower basal metabolic rate and find it more difficult than other people to lose weight. And I think part of managing this is realistic expectation setting. So when we set realistic expectations in patients who we recognize,
is it possible
sorry.
for you to take out your mask because not audible? Or are
Sorry,
you in somewhere in public place?
Yeah, I'm in the airport actually.
Okay.
So
okay, you can continue. Okay.
Am I audible now properly?
Yes.
Okay. So thank you for recognizing that there are people who are fat preservers and find it more difficult than other people to lose weight. And I think in this situation, realistic expectation setting is important. That how much is the quantum of weight which is reasonable for them to lose, and what is the speed with which they will lose weight. So often what happens is when people who are slow fat losers, when they compare themselves to other people who are, they're able to lose weight quickly, then they get disappointed, they get frustrated, and they often abandon everything and go back to what they were doing before. So I think
not audible now. You are muted yourself. Please unmute.
Yeah, sorry, can you hear me?
Yeah.
So if at the beginning we can recognize that this is a person who's going to find it difficult to lose weight, in the endocrine clinic, somebody with acanthosis nigricans, somebody who's always been overweight, was a large child and is now a large adult, has a strong family history of diabetes, then in these patients, realistic expectation setting is something that will really help. Because what happens is not that they aren't able to lose weight, but the trajectory is slower and flatter, and that often leads to disappointment, frustration, and they abandon everything and sometimes maybe just overshoot the weight that they've even lost. So I think that is one thing. Second thing is that it is not possible for everybody to lose weight with lifestyle modification alone, especially if the quantum of weight loss that is required is large. So somebody who is 100 may exercise like crazy, diet like crazy, have a liquid diet and come back to 70 kgs, but they're not going to be able to maintain that degree of weight loss with that intensity of diet and exercise. So in these patients, definitely, not because this is a bariatric surgery conference, but because I believe in it personally. And I do advise my patients that if with this much of hard work, you were losing the weight, and usually within 6 months, they tend to go back a year or more and often overshoot the initial weight. So recognizing realistic expectation setting, and obviously whatever we've described will have to be done for a much, much longer time. Often what happens, somebody ends up injuring their knee, then they can't exercise anymore. A life event happens and they immediately fall off track with the diet. So yes, things are more challenging for these people. And if it's repeated weight cycling, then bariatric surgery should be considered.
Have you used any drugs or L-toxin to increase the basal metabolic rate to reduce obesity?
Yeah, so it doesn't work because we have. So let me give you why I'm telling you very clearly that it doesn't work. So we have patients who come to us for papillary thyroid carcinoma, right? And they are taking
Yeah.
200 to 300 micrograms of levothyroxine to suppress the TSH in that situation.
Yeah.
But they don't lose weight. So I have a lot of overweight, obese people taking 250 micrograms and not losing a single kilo of weight.
Yeah.
And that is why I don't prescribe it.
Okay. Yes, anyone else have any question? Sir, Radal Dilfranzo, you want to comment anything?
No, Dr. DeFranzo, don't ask me a question. I will die of anxiety.
I just want to ask him to question, I mean, his comments on this. Is he there? Okay.
Thank you, Dr.
Yes,
Teji.
Shashank.
Yes, thank you. In spite of being on,
Thank you so much, sir.
being on the
Thank you, Tej. Thank you. Nice to meet you and nice to talk with you.
Thank you, Doctor.
Thank you. Thank you for the kind invitation. Thank you.
Dr. Hardik, can we go to the next presentation? Dr. Girish Parma. Is he live or not live yet? We will call him. Anyway, Dr. Poonam, can you introduce Dr. Girish Parmar and have his presentation started?
Yes, Dr. Parmar is a consultant endocrinologist at the Nanavati Super Specialty Hospital, Mumbai. He has a fellowship in diabetic food disorders from the Manchester Royal Infirmary, UK. He's a faculty for CPS Diabetology and Public Health Foundation of India sponsored certificate courses. He has the Economic Times Award for Endocrinology in 2019, and he has authored and co-authored 27 research papers published in peer-reviewed journal. So we can go ahead with this presentation.
Good evening, everyone. At the onset, I'd like to thank Dr. Shashank Shah for this invite and asking me to deliberate upon this very important topic and an interesting concept of GLP-1 GIP glucagon agonist, also called as dual or triple therapy, that you're looking at for treatment of diabetes along with weight loss. So can I have the next slide? So at the onset, I'd like to discuss that whatever molecules I'm going to talk about are under investigation and are undergoing active clinical development program. I have not used any of them, nor have I been any investigator in any of the research programs so far. So whatever I go to talk about is based on what is available in public domain. Can I have the next slide? So when we talk about diabetes, we've come a long way from the insulin-centric triumvirate theory of pathogenesis of diabetes. We've now moved ahead and we are now talking about the omniscious octet since the last 1 decade, which has been implicated in the pathogenesis of diabetes. And in this, incretin family has been a very evolving family of molecules which have been really implicated in the pathogenesis, and it has changed the way we look diabetes as. Next slide. So as we all know that incretin effect is one of the newer things which is now being actively pursued for treatment of diabetes. And in this family, we understand that these molecules are either deficient or their action is missing, which leads to hyperglycemia. Within this family, it's either the GLP-1 or the GIP or glucagon, which have shown to be causing hyperglycemia to a good extent. So if one was to maneuver these pathways or these molecules, then one can definitely achieve good glycemic control. And on top of that, you have the added advantage of weight loss. Well, the incretin family is now being actively explored because we've noticed following bariatric surgery, the metabolic dysfunction improves remarkably even before actual weight loss is seen.
And that's because of change in hormonal milieu, predominantly the incretin family. The changes in the levels of GLP, GIP, and glucagon, which have been, as in the causative agent responsible for the improvement in metabolic milieu. So let's look at these molecules individually and how they affect the metabolism. Next slide. So let's talk about GLP-1. We all know that these are polypeptide hormones, and GLP is secreted by the L cells of the distal intestine. And at the level of the pancreas,
Mask
GLP-1,
घेतलायस का?
if you talk about the beta cell, it increases or enhances insulin secretion. At the same time, at the level of the alpha cells, it reduces glucagon. So the predominant effect being an increase in insulin, decrease in glucagon, thereby leading to better glycemic control. Apart from that, there are a lot of extra pancreatic benefits of GLP-1. At the level of the brain, it is supposed to be neuroprotective and it improves memory. And this is being now actively pursued in the treatment of neurocognitive disorders like Alzheimer's. Apart from this, at the level of the brain, we know that GLP-1 decreases appetite, it improves satiety, and thereby causes weight loss. This is definitely going to be beneficial because you're going to treat the root cause of obesity, which is the root cause of diabetes. At the level of the heart, GLP-1 is cardioprotective. It improves cardiac output. It improves myocardial contractility and thereby benefits. Obviously, there's a mild increase in heart rate, which is seen with GLP-1 molecules, which is one of the flip side of GLP-1. At the level of the vasculature, it improves endothelial dysfunction and it improves endothelium vasodilatation, which is very important in patients with diabetes. At the level of the adipose tissue, GLP-1 molecules enhances lipolysis and causes weight loss, which is beneficial. So if you look overall, GLP-1 molecules, if GLP-1 agonists are used, definitely you see good degree of metabolic improvement, good degree of weight loss, and cardio as well as neuroprotection. And this is what we've seen in both research as well as clinical practice, because now we have GLP-1 molecules, GLP-1 receptor agonist, which we've been using since almost 1.5 decades. And we have got ample evidence that these are good molecules, GLP-1 receptor agonist, whether it's the short acting or the long acting, they really improve the metabolic milieu. Next slide. So let's look at the second molecule in this family of the incretin pathway. We are talking about glucose-dependent insulinotropic polypeptide, also called as GIP. This molecule, a polypeptide hormone, is now being actively explored, and research have shown some conflicting data as regards to its effect at different tissue levels. So this slide basically depicts what happens once you stimulate the GIP receptor at the level of the brain or the pancreas or the adipose tissue or the bone or the heart for that matter. If I have to give you a crux of GIP agonism, let me have the next slide. It basically, at the level of the pancreas, at the level of the beta cells, it enhances insulin secretion, which improves glucose control. At the level of the alpha cells, unlike GLP-1, GIP basically causes increase in glucagon levels, which is probably not that great. At the level of the brain as well as the heart, the effect of GIP almost similar to that of GLP-1. It offers you neuroprotection, it offers you cardioprotection, just like what is seen with GLP-1. However, In addition, GIP has the added advantage that at the level of the bone, it offers you osteoprotection, it promotes bone formation, it prevents bone resorption, which is one of the advantages of GIP agonism. GIP differs from GLP-1 at the level of the fat adipocytes. GLP-1, just to remind you, it causes more of lipolysis, whereas GIP agonism or stimulation causes lipogenesis. So if you look on a whole, if you were to stimulate both GLP-1 receptors as well as GIP receptors, let's look at what is going to be the advantages and disadvantages. Next slide, please. So at the level of the pancreas, beta cells definite enhanced insulin secretion. At the level of the alpha cells, GLP reduces glucagon, whereas GIP is going to enhance glucagon. So the net result probably is going to be G-glucagon neutral. On the other side, at the level of the brain, both are neuroprotective, improves neuronal plasticity, and definitely, at least the preliminary results have shown it reduces the cognitive dysfunction, which is seen in Alzheimer's. At the same time, at the level of the brain, both the molecules act in synergism or have an additive effect as far as decreased appetite and promotion of satiety is concerned, culminating into good amount of weight loss. At the level of the heart, both GLP-1 as well as GIP offers you cardioprotection, enhances cardiac output by enhancing the cardiac contractility, as well as at the level of the vasculature, it improves endothelial functioning. GIP also has the advantage that it offers you osteoprotection. At the level of the adipose tissue, GLP-1 basically causes more of lipolysis, whereas GIP causes more of lipogenesis. So probably the net result may be neutral if one has to take on a 1:1 basis, an effect of both. Next slide. Let's look at the third molecule, namely glucagon, which is involved in this family of incretins. Glucagon, as we all know, is a major counter-regulatory hormone which increases during hypoglycemia. So definitely glucagon, if you look at the effect of glucagon stimulation, glucagon receptor stimulation at the level of the pancreas on the beta cells, glucagon causes an enhanced insulin secretion. At the level of the brain, glucagon reduces food intake, it improves satiety, culminating into good amount of weight loss. Stimulation of the glucagon receptors at the level of the adipose tissue causes more of browning of adipose tissue. It increases the resting energy expenditure, leading to good amount of weight loss. At the level of the heart, glucagon stimulation also causes increase in cardiac output, increased cardiac contractility with a mild increase in heart rate, which is seen with glucagon receptor agonism. So the net result, if I have to see, if I give a molecule which is capable of acting on the glucagon receptor or on the GLP receptor or on the GIP receptor simultaneously on all these three receptors, then definitely what you would note or what you would expect is enhanced insulin secretion, better glucose control, enhanced weight loss, because all these three molecules, once their receptors are stimulated, they decrease food intake, they enhance satiety. At the level of the adipose tissue, you're going to see more of browning of adipose tissue. You're going to see a more reduction in adipocytes. And therefore, the benefit that you have with simultaneous stimulation of all these three receptors would be good glycemic control, good amount of weight loss, which is what seen following bariatric surgery. And taking a cue from these results post bariatric surgery, this pathway is actively being explored upon as a therapy for improvement of metabolic dysfunction, improvement in obesity. Next slide. So if you look what is common in all these three molecules in the incretin family is that these are polypeptide hormones, and all of them act via a G protein coupled receptor. So they share a great degree of homology in their sequence. And if you have molecules which are either a fusion, or if you have a balanced hybrid which can stimulate either two of these receptors or three of the receptors, you can see the benefits of all the three molecules or two molecules respectively. And now we have molecules which are being explored and investigated. Modified amino acid sequence, you can have either a balanced fusion or an imbalanced fusion, or you can have a balanced hybrid molecule which is capable of acting at all these three receptors at different sites. What we call it as multi-agonist or polyagonist molecules or ligands. Next slide. So you're looking at a molecule which is capable of not only acting at either the GLP-1 pathway or receptor, simultaneously it is capable of acting at the level of GIP receptors or the glucagon receptor. So you're doing a fusion, something similar to what this modified CAR was. You have a lot of multi-agonist molecules under clinical trial actively being pursued in phase 1 and phase 2 trials, which have the capability of simultaneous stimulation. You have dual or triple agonist molecules which are being actively explored upon. I'm going to take you through a couple of these molecules and the research so far being done. Next. So this is LY3298176 molecule, a molecule from Eli Lilly, also called as GLP-GIP, which is capable of stimulating the GLP-1 and GIP receptor. It's an 39 amino acid linear peptide, which is conjugated to a fatty acid moiety to prolong its half-life. It is a multifunctional peptide based on native GIP peptide, modified to bind to the GIP and GLP-1 receptors. It has a half-life of about 5 days, enabling once weekly dosing. So this is a good molecule capable of stimulating GIP as well as GLP-1 receptors. Next slide. So this study was presented at ESD 2018. And this was a phase 2 study, which was dose finding study. And this molecule, or GLP-GIP as we call it as, was used at different doses compared with dulaglutide as well as placebo in the other arm. So since this was a dose finding study, different doses of these molecules was studied, 1 milligram, 5 milligram, 10 and 15 milligram respectively, when compared to placebo and dulaglutide used as 1.5 milligram once a week dosing. Obviously, these were type 2 diabetic patients who were uncontrolled. Next slide. And what you noted was, if you look at this study, which is a 26-week study, yes, since it was a dose-finding study, a small number of patients, and a short duration of study. But as expected, if you note, compared to only a GLP-1 receptor agonist like dulaglutide, which is a good molecule, we note that when you have simultaneous stimulation of GLP-1 receptor as well as GIP receptor, you note that with a dose of this molecule at a dose which is maximum, you see a greater degree of reduction in HbA1c vis-a-vis dulaglutide alone. The weight loss that you see with dulaglutide on an average is about 2.7 kilograms, but the weight loss that you see with this molecule at a dose of about 15 milligram is to the extent of 11 kilos. So much greater weight loss when you have simultaneous stimulation of GLP-1 and GIP vis-a-vis only GLP-1 receptor stimulation. The HbA1c reduction is also much greater. With dulaglutide, you see a reduction of 1.1 in A1C, but with this molecule, GLP-GIP, the reduction in A1C is to the tune of 2.4%. So you note the amplified effect of this molecule when you have simultaneous stimulation of GLP as well as GIP. So with a GLP-1 molecule, we all know that the reduction in A1C is to the extent of 1%, whereas in this molecule, 2.5%. The reduction in weight loss with GLP is about 2.5 kilos. In this molecule, almost about 11 kilos. That means on an average, individuals can lose 15 to 20% of body weight, which is what we want in most of our obese diabetic patients. Good glycemic control, good reduction in weight. Next slide. Well, if you look, the maximum dose of this molecule, GLP-GIP, which is 15 milligrams, the effect was phenomenally encouraging and better. But obviously, GI tolerance or GI side effects also increased, namely nausea, diarrhea, vomiting. So these were definitely high. What was also not studied in this study to a great extent was the risk of pancreatitis. So that caveat is there, but I'm sure research is going on and we'll come to know about it very soon. What happens to incidences and occurrences of pancreatitis. Next slide. So there's been an impressive reduction in A1C as well as weight with this twincretin or GLP-GIP, which is simultaneous stimulation of GLP-1 and GIP receptors. Next slide. So this molecule is now being actively pursued by Eli Lilly, and it has a very robust clinical trial program which is ongoing, and the results are very, very encouraging. So in order to mitigate the gastrointestinal side effects which occur at an increasing frequency with simultaneous stimulation of GLP and GIP, the common practice has been so far gradual dose escalation. So this is what is now being even used even for twincretins. Next slide. Medi 0382 is an other molecule which is being explored upon. It is simultaneous stimulation of GLP-1 receptor and glucagon receptor. So I showed you one molecule which is simultaneous stimulation of GLP, GIP, and now another molecule being actively explored upon with simultaneous stimulation of GLP-1 and glucagon. And in this study, you compare this molecule with placebo, and this is phase 2A study, again dose finding, and what doses were used was about 300 micrograms with 1 or 2 weekly titration in this trial. This was again presented at ESD 2018. As I said, this is phase 2. The duration as well as the number of patients are going to be relatively smaller. Next slide. Next. Yeah. So if you see the results compared to placebo, the reduction in weight was about 3.3 kilograms for a very short duration of time. You see encouraging results in HbA1c with simultaneous stimulation of GLP-1 and glucagon receptor. Yes, risk of side effects, GI tolerance definitely is there. Even with simultaneous stimulation of GLP-1 and glucagon, you would note an increase in heart rate, because both these molecules individually would definitely increase the heart rate. So simultaneously given, simultaneous stimulation of both the receptors would lead to an increase in heart rate, and this is what we would want to keep a watch on. Next slide. So the results of this study indicate at highest dose of about 300 micrograms of this molecule, the weight loss that you see is definitely better. Glucose control is definitely better. Now it's being actively looked upon in comparison to liraglutide. How does this fare? And they are also actively pursuing it in combination with dapagliflozin. Next slide. So I spoke about twin cretins or dual agonist. Let's talk about triple agonist, that is simultaneously stimulating GLP-1 receptor, GIP receptor, and glucagon receptor. And there are molecules in this, molecules which are capable of acting on simultaneously on all these three receptors and stimulating them, leading to downstream signaling and yielding good metabolic control, good control of weight loss, I would say. And these are all phase 2 studies, phase 1 and phase 2 studies, which these molecules are undergoing. Next slide. Triple agonist or triagonist definitely represents a sizable step forward beyond previous attempts of co-agonism and reflects the growing notion that a single molecule polytherapies definitely are emerging as the gold standard for treatment of diabetes as well as obesity. It is conceivable that this newly discovered triagonist or triple therapy could be used to deepen and broaden the efficacy in targeting of nuclear hormones, or find application in combining with other protein-based therapies as we search for newer and newer drugs which improves the metabolic milieu, which can be offered upon as alternatives to bariatric surgery, which in some patients may not be possible due to cost economics. Next. If you look at this slide, it shows you one such molecule, which is a triple agonist, which stimulates GLP.
I think we lost connection with Dr. Girish Parmar. I think he was traveling. Anyway, we can get him again. We will go to the next presentation by Dr. Altamas. He is already live online. Dr. Altamas, yes. Dr. Poonam, will you introduce Dr. Altamas? Thank you, Dr. Altamas, for joining and accepting this invitation. Just one request, Dr. Ralph DiFronzo is online and live. He has his presentation at 5:35. I'm sure you will cover it, but the question answers we will keep after DiFronzo's lecture.
Sure. Yes, sir. We'll do that.
Thank you so much. Yeah.
Thank you so much. Yeah, so Dr. Altama Sheikh has the Best Paper Award, Indian Journal of Endocrinology and Metabolism, in the 42nd Annual Conference of ESICON in 2012. He is the 9th state rank in MBBS Phase 1 in 2011, second rank in MBBS Phase 3, Best Outgoing Medical Student, distinctions in Anatomy, Biochemistry and Ophthalmology, first prize in Pediatric Endocrinology Training, quiz conducted by the Indian Society of Pediatric and Adolescent Endocrinology. Welcome, Dr. Altamas, and we're looking forward to listen to you. Thank you.
Thank you so much, Dr. Poonam, madam. And please allow me to start my video. I think the host has to give that permission. I was able to see myself all this while.
Yes.
And also allow me to share my PPT also, please, if it's possible. Okay.
You are sharing, Dr. Hardik?
No, I'll be sharing, madam. I'll be doing it. And I think I have got a very big step of presenting in front of Dr. Ralph DeFronzo and Dr. Shashank Shah has already given me a hint that finish it in 7 to 8 minutes, which I'll be doing it. Please let me know when I'm done with in around 6 or 7 minutes. So MetaSearch 2021, pharmacotherapy for obesity in Indian scenario, what more can be expected? We've been listening to a lot of talks about diabetes, obesity, and the drugs that are used in this context. I have no conflict of interest for this particular talk. I would take you through very quickly the perspectives about why should a drug for obesity be required, a medical drug, what are the prerequisites that the drug should do, what's happening in the Indian scenario, why are we talking so specifically, why did Dr. Shashank Shah give us this particular topic, which drugs we have currently in India which are approved but are unavailable, and some drugs which are unapproved are used and are available and have shown some efficacy in weight loss, a touch upon international guidelines and how do we apply to our patients, futuristic weight loss, a very surprising thing that is there a vaccine for weight loss, and the truth that yes, more can be expected from the given topic. So looking at the last 40 years, what we have seen is obese adults have almost 7 times increased compared to the obese adolescents, which are around 10 times increased in India. Why we need to use a drug for obesity is because we need to get into a reduced calorie diet with increased physical activity. And that is when exactly the drug, when you use, it will be useful irrespective of BMI, except for those patients where surgery is straight away. And I agree with my previous speakers that yes, we do send patients for surgery when they have a lot of complications and when they have an indicated BMI for the same. So which drugs should we choose for our population, especially those who've shown a weight loss of more than 5% at 1 year? Please look into this. It is more than 5% at 1 year, or more than 35% of patients should achieve more than 5% weight loss, which should be double that of the placebo.
Sorry to interrupt you. Sir, your slide is not visible.
Improvement.
Hello, sir, your slide is not visible, sir.
But I'm able to see the slides.
No, sir. Put it on slideshow mode once.
It is on slideshow mode now.
No, sir. It is coming only black window.
Okay, how do we solve this?
Please close your presentation once and reopen the presentation and stop share your screen once.
Stop share and restart. Okay.
Yes. And also close your presentation once and reopen the presentation.
Okay. Just see whether you're able to see now. Is this
yes, it's visible? It's visible.
Okay, so that was the agenda, ladies and gentlemen, that we were trying to give you, and I think very quickly we'll come to an end of the whole thing within a few minutes. This is what I just read about the agenda, and there was 2 slides that I was just talking about. And obesity, which is a bigger threat compared to any other non-communicable diseases in India, where it stands for around 46%. We have now 19 states with more than 15% of weight in just 1 decade. This is now a very alarming thing in India about the weight loss and the weight gain. So the weight loss, improved obesity related complications are these. Generally, it is 3 to 10%, which will give you any kind of benefit if you see this, as well as if you see the lower part of this particular slides, which is around osteoarthritis, GERD, PCOS, and also. So we need to have a drug which would be effective at least 3 to 10%. And these are what is the other existing weight loss strategies that we have already with us. And we take it from here about the intervention with drugs. The obesity guidelines are enormous. If you take from 2014 till precisely up to the Canadian guidelines, which came, and the European Gynecological Society guidelines, which came last year amidst the COVID. From being BMI centric, now we have a lot of guidelines which are now complication centric. And this also talks about that the pharmacotherapy may be used to maintain the weight loss that has been achieved by health behavior changes and to prevent weight regain, which is so important. So which are the drugs that we are using currently, and how do we move ahead for an Indian scenario? This is changing and challenging because of myriad of genetic, developmental, biological, and a lot of iatrogenic factors too, including the environment that the patient stays, even while he or she is with behavioral changes, intensive behavioral changes, and a lot of other drugs. So what we understand is we have drugs available currently which act either on the brain or on the intestine, as we have the orlistat or the dual agonist that my previous speaker spoke about, for obesity, and drugs which are available as single receptor analogs or GLP-1 analogs. So we do not have exactly a short-term approved drug over here, but we do have a long duration of treatment approved drugs, and that's the lipase inhibitor that we talk about. At least 3 to 6 months of time should be given when you start this particular drug. And these are the drugs which came with efficacy of around 5.8 to 3 kg in around over 4 years. And that trial was Zendos, and that it has to be taken 3 times with meals and maybe started as over the counter in some countries with as small as a 60 milligram per day dose. Also, there have been a risk of fat soluble vitamin deficiencies which can be taken care with a lot of supplementation of vitamins, and we take it from there. So cetulistat is also available in India, and some people have used it, but however the efficacy is not as good as the orlistat. So I think we do prefer in our scenario the orlistat. Again, naltrexone for alcohol rehabilitation and bupropion for smoking, but in India we have a monotherapy used by some people as the bupropion monotherapy, started as 150 milligram per day. Of course, this is with obesity, depression, and smoking, where it can help. And the trial was CORE1 as well as CORE2. And prior to COVID, this was the result that we were looking for. But I think after Saxenda started coming and started showing results, and after liraglutide, we now have semaglutide, which has shown good results about this year. And we also have one more drug which came into comparison apart from this, which was setmelanotide, which came just last November in 2020 for a specific cause of obesity. And we have some patients on trial basis on this particular drug also, whether it was POMC deficiency, leptin receptor deficiency, or PCSK1. So these are the drugs now we have in pipeline completely, which is tesofensine or methylphenidate, semaglutide we discussed already in the earlier slides, as I said, mirabegron, oxytocin intranasal spray. We have combinations of canagliflozin with phentermine. We have drugs, very interesting drugs like sildenafil and tadalafil for being used as a centrally acting drug for obesity. We have dulaglutide, we have SGLT2 and SGLT1 upcoming in various trials, and talking about these receptors with so many peptides are coming, and also that we discussed dual and triple agonist in the previous slide. I would skip those, and I think this would be my concluding slide, so that Dr. Ralph DeFronzo completely comes as requested by the organizers. Pharmacotherapy for obesity, give a realistic application to the patient, realistic goal to the patient. It has to be told to the patient that it is an adjunct only. Set realistic goal. Weight loss is a process. Tell them the short term, the interim goal, as well as the long term goal. And I think with this and respecting the permissions from organizers, I give the session back to Dr. Shashank Shah. Thank you so much for having me here. Thank you.
Thank you so much, Dr. Altamaz. We would be happy if you can stay and attend Dr. Ralph DeFronzo's presentation.
Yes, sir. Yes.
Hardik, can we have Dr. Ralph DeFronzo's presentation? Dr. DeFronzo, thank you for being with us. It's a great honor to have him here, the world-renowned personality. No need to introduce him. I must thank him for hosting me in University of Texas when I visited him. May I request Dr. Abbas to introduce him, please?
Yeah, thank you, Dr. Shashank. And it's a sheer pleasure to introduce Professor Ralph DeFronzo. Once in a lifetime opportunity, somebody gets to introduce this stalwart in the field of diabetology. He's, as Dr. Shashank said, well known to each and everyone across the globe, but to just do the formalities without taking so much of time, he's the Professor of Medicine and Chief of Diabetes Division at the University of Texas Health Science Center, and also the Deputy Director of the Texas Diabetes Institute in San Antonio, Texas. He has the Benting Award from the American Diabetes Association in 2008 and also the Claude Bernard Award from EAST in 2008, the Ham International Prize in 2017. He's famous for so many publications which he does each and every year, more than 800 now to his credit in peer-reviewed medical journals, and he's famous for his work with metformin and also with establishing SGLT2 inhibitors and many other therapies, and is a very sought after speaker in both international as well as global congresses. So, Professor DiFronzo, we would be very interested to know from you about the role of SGLT2 and GLP-1 in heart failure, and how do we treat this new indication. Now, I think we were more interested with diabetes, and then we thought that heart failure as a serendipity has come up. So we'd love to hear from you, Professor DiFronzo. If you can unmute, yeah. You are on mute, Professor DiFronzo.
Okay.
Yeah, good to go.
Good morning in India. It's very early here. But I want to thank Dr. Shashank for inviting me to participate. But my understanding is that you have my recording and you're going to play it, and then I will stay on board to answer questions.
I think you can get the presentation.
Good evening and welcome to this webinar on SGLT2 inhibitors and GLP-1 receptor agonist, cardiorenal metabolic drugs for the ages. I'm Professor Ralph DiFronzo, and I'm Chief of the Diabetes Division at the University of Texas Health Science Center here in San Antonio. In the next 15 to 20 minutes, I'm going to take you through really some amazing breakthroughs have come with the use of these two classes of drugs, which really have revolutionized our treatment of patients with type 2 diabetes. Because now we have medications that not only will lower the blood sugar level and prevent the microvascular complications, but also will prevent the macrovascular complications. And it's really an exciting time now to be in the field of type 2 diabetes. So let's get started. And let's start with the SGLT2 inhibitors. And I'm going to discuss three aspects of the SGLT2 inhibitors. Let's start with the metabolic benefits of this class of drugs. As some of you who are listening in may know, I invented the SGLT2 class of drugs. And we were the first to demonstrate that people with type 2 diabetes have an elevated threshold for spilling glucose in the urine. So when you and I, our threshold for spilling glucose into the urine is a plasma glucose concentration of about 180 milligrams per deciliter. But in people with type 2 diabetes, that threshold increases markedly, and it increases in proportion to the level of glycemic control. So in people who have a hemoglobin A1C that's 8 to 9, the threshold may be as high as 240, 250 milligrams per deciliter. The SGLT2 inhibitors lower that threshold, and in doing so, allow the glucose to come out in the urine. And as the blood sugar now starts to drop, we reverse what we call glucotoxicity. So elevated glucose levels poison your beta cell, they inhibit insulin secretion, and they also cause insulin resistance. So now, as the blood sugar level comes down, we're going to improve beta cell function, and we're going to improve insulin sensitivity. In our original studies, we showed that insulin sensitivity improved by about 35 to 40%, and beta cell function improved by 98%. So these improvements in these pathophysiologic defects are going to lead to a nice reduction in the hemoglobin A1C. Now, because we're also losing calories in the urine, our people are going to lose weight. That's very good because obesity is an insulin-resistant state. And as you become more sensitive to the insulin, you take the stress off your beta cells, and you will preserve beta cell function. We also know, because these drugs work on the kidney, that's a very different mechanism of action than all the other drugs that are currently available. So we can use these drugs in combination with any other approved drug for the treatment of our diabetic patients. Because these drugs block not only glucose reabsorption, but sodium reabsorption, we get nice drops in blood pressure, about 5 to 6 systolic, and 1 to 2 diastolic. And very importantly, these drugs do not cause hypoglycemia, which makes them very easy for people to use, whether you're a primary care physician, whether you're an internal medicine doctor, whether you're a cardiologist, an endocrinologist, or a nephrologist. Now, because these drugs improve a number of cardiovascular risk factors, one might also predict that these drugs would give cardiovascular protection. And in fact, we now have a large number of cardiovascular outcome trials demonstrating that the SGLT2 inhibitors can decrease the MACE endpoint. We'll come back to this in a second, and can decrease hospitalization for heart failure. So let me first address the issue of cardiovascular disease and type 2 diabetes. So when you see a newly diagnosed type 2 diabetic patient, over 2/3 of them already have subclinical cardiovascular disease, and another 15 to 20% have clinically manifest cardiovascular disease. And as I think most of you are aware, the great majority of the mortality, some 70 to 80%, in our type 2 diabetic patients is attributable to cardiovascular disease. And we know that the cardiovascular disease manifests itself some 15 years earlier in people with type 2 diabetes than in non-diabetic individuals. Now, as our diabetic population is living longer, we're seeing a lot more heart failure. And heart failure has increased some 2 to 3-fold in our diabetic patients. And if you have a diabetic patient with kidney disease, the cardiovascular mortality increases even further, some 3-fold. So when you're taking care of diabetic patients, you have to focus, of course, not only controlling the glucose, but also in intervening with medications that are going to prevent these cardiovascular complications. So the very first study showing the benefit of this class of drugs was done with empagliflozin, and this is the EMPA-REG outcome study. And as we read from left to right, you can see the MACE endpoint, and MACE stands for Major Adverse Cardiovascular Events, and there's a triad of them. It's non-fatal MI, non-fatal stroke, and cardiovascular mortality. It was decreased by 14%. So the hazard ratio was 0.86, highly statistically significant. If you look in the middle and you look at the effect of empagliflozin on cardiovascular mortality, you see this dramatic 38% decrease, a hazard ratio 0.62, highly statistically significant. And if you look at hospitalization for heart failure, again, a very dramatic decrease. And the other thing I want to point out is if you look here on the time schedule, you can see that these benefits on mortality and in hospitalization for heart failure are seen within the first 3 months of therapy. Now, I'm not going to take you through every individual cardiovascular outcome trial that have been carried out with the SGLT2 inhibitors. Instead, what I've done here at this slide is I've summarized for you these results on one slide. So the EMPA-REG outcome study is shown in purple. The DECLARE study with dapagliflozin is shown in yellow, and the CANVAS study with canagliflozin is shown in green. You can see all three decrease the MACE outcome. If you look at cardiovascular death, it might appear that there's a difference between these drugs. But what I'm going to take you through is that it's most likely that the differences that we see in cardiovascular mortality are more related to the patient population than the drug itself. So if you look at the EMPA-REG outcome study here in purple, as I showed you, there's about a 40% decrease in cardiovascular death. This is exactly what you would expect, because in the EMPA-REG outcome study, 100% of the people who got into the study got in because they had had a previous cardiovascular event. So they're the sickest people. So they're most likely to benefit in terms of cardiovascular mortality. If you look at the DECLARE study, which is in yellow, this was the least sick population, with 2/3 of the people getting in because they had risk factors and not because they had a cardiovascular event. So you can see they really didn't benefit much in terms of mortality. And you can see with the canagliflozin, intermediate in terms of risk, 2/3 of them had a previous event, and you can see an intermediate reduction in cardiovascular mortality. If you look at non-fatal MI, all three similarly decreased non-fatal MI. If you look at non-fatal stroke, this was a surprising finding to us because these drugs dropped the blood pressure quite significantly, yet we did not see a benefit in terms of stroke, and we still really do not understand why we didn't see this benefit. If we look at hospitalization for heart failure and improvement in myocardial function, you can see all three of these drugs, dramatic effect, hazard ratio is about 0.7. And then even more dramatic is this marked reduction in the renal composite outcome, which we'll come back to in a minute, with a hazard ratio of about 0.55 to 6. So these drugs are very powerful in reducing cardiovascular events and in preventing progression to renal disease. Now, there also have been now two big studies, one with dapagliflozin and one with empagliflozin, in terms of prevention of heart failure. And the results are really quite similar. I'm going to show you the dapagliflozin data. So here, these are people with heart failure and reduced ejection fraction. And we look at the primary composite endpoint, which is hospitalization for heart failure, cardiovascular death, and emergency room visits for heart failure. Most of these people had class 2-3, New York Heart Association heart failure. Now, if we look to the left in the panel, the primary outcome, you can see here, hazard ratio is 0.74, highly statistically significant reduction. In the middle, hospitalization for heart failure significantly decreased. And very importantly, to the right, cardiovascular death significantly decreased. Now, the important thing in this study is that it included both people with diabetes and non-diabetes. So these SGLT2 inhibitor drugs work not only in the diabetic population in preventing heart failure and cardiovascular mortality, but also in the non-diabetic population as well. Let's now turn our attention to the GLP-1 receptor agonist. This class of drugs effectively reduces the A1C, and they do so because they have a very powerful effect to preserve beta cell function. In fact, the only other class of drugs which has such a powerful effect are the TZDs, namely pioglitazone. These drugs inhibit glucagon secretion. They're excellent drugs in promoting weight loss. I'm not going to be able to go through the pathophysiology of type 2 diabetes with you because we have a limited amount of time, but there are 8 major pathophysiologic disturbances, and 6 of those disturbances are corrected by the GLP-1 receptor agonist. So as we said with the very first bullet point, these drugs are very good drugs at lowering the A1C, and like the SGLT2 inhibitors, they do not cause hypoglycemia, and they have an excellent safety profile. Now, what we've also learned is that these drugs are very good in terms of decreasing cardiovascular events. So there have been 4 big trials. I've summarized them here for you on one slide. So reading from left to right is liraglutide in the LEADER study, 13% reduction in the MACE endpoint. Semaglutide in the SUSTAIN 6 study, a 26% reduction in the MACE endpoint. With exenatide bidurium, you can see that the hazard ratio of 0.91 did not quite reach statistical significance, p-value 0.06. But in this study, there was a large drop-in of SGLT2 inhibitors in the placebo group. And if you were to reanalyze the data, removing the SGLT2 inhibitors, you would find that this was highly statistically significant. And to the far right, we have dulaglutide in the REWIND study. Again, a very similar reduction in the hazard ratio. Now, the important thing about dulaglutide in the REWIND study is that people who had had a previous cardiovascular event, as well as people who had risk factors without a cardiovascular event, all benefited from the MACE endpoint. So it's telling us we should be using these drugs much earlier in the natural history of type 2 diabetes before people have a cardiovascular event. Now, let's look at kidney disease, and let's start with the SGLT2 inhibitors. Now, in all of the big cardiovascular outcome trials, there was a renal endpoint, which was worsening renal failure, end-stage renal disease, or progression to dialysis or to transplantation. And unfortunately, in the cardiovascular outcome trials, these were secondary endpoints. So the FDA does not give approval for secondary endpoint. But let me take you through these secondary endpoints before I get to the trials which had renal disease as the primary endpoint. So let's start here at the top. There were some people who had established cardiovascular disease in all of the trials. So Emphroreg, as I told you, 100% of the people had a cardiovascular event. Canvas, 2/3 did not have a cardiovascular, 2/3 did have a cardiovascular event. And in Declare, 2/3 did not have a cardiovascular event. And if we look at this composite renal outcome, you can see all the points fall to the left of the hazard ratio of 1 with a mean value of 0.56, meaning a very impressive 46% reduction in this composite renal outcome. Now, if we look at the two studies in which people got in because they had risk factors, that Canvas and Declare, again, if you go to the right, points are to the left of the identity line of 1, hazard ratio is 0.54, meaning there's a 46% reduction in this composite renal outcome. But as I mentioned to you, the FDA does not give approval for secondary outcomes. But there have been two. The first one was Credence, in which the composite renal outcome was very similar to the one that I just reviewed with you. You can see here hazard ratio of 0.66, 34% decrease in progression to end-stage renal disease, dialysis, transplantation, doubling of your serum creatinine, a 40% reduction in GFR. The curves separate here at about 1 year. They continue to separate, and very highly statistically significant difference in the people treated with canagliflozin. Now, let's look at DAPA-CKD. Very similar, in fact, even more robust results with a hazard ratio of 0.56. But the important point of DAPA-CKD is that 55% of the people in DAPA-CKD had non-diabetic renal disease. So what this is telling us is that the mechanisms that cause progressive renal disease are very similar in people with diabetes and non-diabetes, and they're similarly affected by the SGLT2 inhibitors. Now, let's take a look at the kidney in terms of the mechanisms that contribute to the kidney disease. So when I gave the Banting lecture at the American Diabetes Association, I called it From the Triumvirate to the Ominous Octet, a new paradigm for the treatment of type 2 diabetes. And I outlined the 8 pathophysiologic defects responsible for hypoglycemia in people with type 2 diabetes. Well, it turns out there's an ominous octet for diabetic nephropathy as well. So let's take a quick look at this. Of course, if you control the blood sugar, you're not going to develop diabetic kidney disease. So the most important thing that we can do in our diabetic patients is make sure that the hemoglobin A1C is less than 6.5. We know that the single most important factor that accelerates the decline in renal function is hypertension. So we need to maintain meticulous blood pressure control. That means less than 120/80. We also know that there's deranged tubulo-glomerular feedback. The SGLT2 inhibitors correct this defect at the level of the kidney. We know that because of this heavy reabsorption of glucose in sodium and the proximal tubule, that sodium that's in the proximal tubule needs to be pumped out by the sodium-potassium ATPase pump. That requires energy and that requires oxygen, and the kidney is hypoxic, leading to reactive oxygen species stress, inflammation, fibrosis. Those podocytes, with their foot processes, form the barrier that prevents albumin from getting in the urine, are injured in people with diabetes. That lets albumin leak into the urine, and albumin is very toxic to the kidney. We also know that most of our diabetic patients are overweight, and this is lipotoxicity. So fat in muscle causes insulin resistance. Fat in liver causes NASH and insulin resistance. Fat in your arteries causes coronary artery disease. Fat in your glomeruli and mesangial cells and tubule cells it plays a very important role in the development of diabetic kidney disease. And SGLT2 inhibitors are very good at mobilizing fat out of the kidney. We also know that there's tubular hypertrophy with release of growth factors, which increase the intraglomerular pressure. And then lastly, there's a genetic component, which we don't really understand. And we have lots of thoughts about some genes that are involved, but we have yet to identify those which are the real culprits. Now, what about the SGLT2 inhibitors? You can see by the stars, they correct 6 of the 8 problems. So they are going to be excellent drugs for the prevention of diabetic nephropathy. Now, if we have 8 different pathophysiologic disturbances that contribute to the diabetic nephropathy, it's obvious that we're going to need multiple medications to slow or halt the progression of the renal disease. So we've had the ACEs and ARBs, but despite the fact that we've had the ACEs and ARBs, and they are good drugs, there's still a very high incidence of progressive renal disease. We now have the SGLT2 inhibitors, and the SGLT2 inhibitors, all the studies were carried out in people who were taking ACEs and ARBs. So we know that we're going to get an additive effect here. We now, more recently, have had a mineralocorticoid receptor agonist, a non-steroidal one, feninerone, the Fidelio study, recently published in the New England Journal of Medicine, which shows both renal and cardioprotective effects, which can be added to the ACEs, ARBs, and SGLT2 inhibitors. And although we don't have a definitive study, I'm going to come back to this in a second, there also is evidence the GLP-1 receptor agonist also may be playing a very important role in renal protection. So here now is the Fidelity study. If you look to the left, this is the renal composite outcome, which is end-stage renal disease, dialysis, transplantation, reduction in GFR to less than 15, or a decrease of greater than 40% in renal death. Hazard ratio for renal protection of this composite outcome, 0.82, highly statistically significant. Again, you see the curves start to separate out here at about a year. If we look now at the key secondary outcome, which was a cardiovascular one, so this is cardiovascular death, the MACE endpoint, hospitalization for heart failure, hazard ratio 0.76. So you see here we have now another drug like the SGLT2 inhibitors, which gives us not only renal protection, but cardiovascular protection. And although this drug has yet to be approved by the Food and Drug Administration in the US, I'm quite confident that it eventually will be approved, then giving us at least 3 drugs. Now, what about the GLP-1 receptor agonists and their effect on the renal composite outcome? There have been 5 trials, and I've shown them to the left: Elixir, Leader, Sustain, 6, Excel, Rewind, all showing a reduction in this renal composite outcome. But in this renal composite outcome was included proteinuria. And proteinuria, albuminuria, is really not such a great indicator of renal disease. So this meta-analysis was done with proteinuria. It is highly statistically significant, hazard ratio 0.83, p-value less than 0.001. But now what happens if we take out proteinuria and we repeat the meta-analysis? You can see in 2 of the studies, the points fall to the right of the hazard ratio line of 1. And the mean hazard ratio is 0.87, and it's borderline statistically significant. So we don't have a definitive answer yet about the GLP-1 receptor agonists and their protective effect on the progression of renal disease in people with type 2 diabetes. But we do have the FLOW study that's being conducted by Novo Nordisk, and we'll have to see what the results of this show. So what can we conclude about the SGLT2 inhibitor and the GLP-1 receptor agonist? These drugs are exceptionally effective in lowering the A1C. They lower the blood pressure. they promote weight loss, and they don't cause hypoglycemia, and they can be used in combination. And this is a great combination therapy for our diabetic patients. And not only can they be used in combination with each other, they can be used in combination with all other anti-diabetic agents. They, very importantly, both classes of drugs reduce the MACE endpoint in type 2 diabetic individuals who are at high risk or who've had a previous cardiovascular event, and they slow or prevent the progression of diabetic and, importantly, non-diabetic kidney disease. So in my opinion, these two classes of drugs should be considered as first-line therapy in all type 2 diabetic patients. And in fact, I favor them, both of these classes of drugs over metformin, and I favor institution of therapy with combination of both the SGLT2 inhibitor and GLP-1 receptor agonist. My other two favorite drugs are pioglitazone and metformin, and in actuality, I always start my patients on triple therapy, and I know that sounds somewhat aggressive, but I can tell you the EDIC study is now published, the 3-year data, and the 6-year data are being written up. And in the EDIC study, we showed really quite dramatic benefits using a combination of a GLP-1 receptor agonist and metformin and pioglitazone. At the time EDIC was initiated, we didn't have an SGLT2 inhibitor, but I think that actually would probably be better than even metformin. So I hope this was informative and provocative, and I look forward to the question and answer period, which is coming up. Thank you very much for your attention.
Yeah, Dr. Shashank, should I ask some questions or you think?
Yes, please. Yes, please. And can you start my video, Hardik?
Yeah, even my video is disabled. Yeah.
Thank you so much, sir. Wonderful presentation, and thank you for coming so early in the morning. Dr. Poonam is my wife. She always wanted to see you and say hello. So hello from Dr. Poonam. We really look forward to visiting you again. There are more than 400 delegates who are listening to you. Many endocrinologists. We have Dr. Bansi Sabu, founder of Diabetes India and chairman of DiaCare, who is live here. Dr. Abbas Shah is here, and many people. So I'll keep it open for 1 or 2 questions. But before that, I must tell you, I enjoyed the ride in the car where the number plate is diabetes. And that probably first time in the world I saw, and everything about diabetes, the research facility, everyone must know it's out of the world research facility. Thank you, sir. I keep it open for any question answers, and we don't have any time limit to have more time with Dr. Rao.
Yeah, sure. I'll just have 2 or 3 questions, Professor DiFronzo. First one, you talked about the heart failure benefit. So now we need to know what is the timing of the therapy and what should be the sequence. So in a acute heart failure patient who is now stabilized, so first of all, when do you want to start it, during discharge, or maybe 5 to 10 days after the discharge, or maybe few weeks after discharge? And then which therapies you would like to try first, the tried and tested ones like ACE, ARB, and going to the maximal dose, and then maybe after a couple of weeks we go for ARNI and then SGLT2, or how is your sequence now in heart failure? You are on mute, Professor, if you can unmute.
So you're on mute. Can you unmute yourself?
Yeah, Professor DiFronzo, you're on mute.
Yes.
All right. Okay, better?
Yeah.
Can you hear me now? Yeah, I think the answer to that question comes from the DAPA study. And in that heart failure, DAPA heart failure study, what they showed that if you started the SGLT2 inhibitor, dapagliflozin, within the first year, within the second year, I'll come back to how quickly in a second, you got the maximum benefit. However, if you waited to start the dapagliflozin until year 3, the protective effect and hospitalization for heart failure was lost. So the sooner the better. So how soon? I would say the sort of most judicious thing to do is to maximize, based on current guidelines, we use the American College of Cardiology guidelines to maximize your therapy with the sort of more established drugs. So that means ACEs and ARBs, diuretics, Entresto, etc. And the average person usually ends up being on 4 drugs. And then once that's maximized, and that usually is done within the hospital, we then suggest that within 1 to 2 weeks after hospital discharge, that you start the dapagliflozin or empagliflozin or canagliflozin. So relatively quickly, we generally don't start it within the hospital because they tend to be a little bit more unstable, and we want to maximize the sort of standard regime. So in a certain way, the sooner, the better. I think the real issue, which is not understood, is what if you move much earlier in the natural history of the disease, long before you even developed heart failure, and now you were to start an SGLT2 inhibitor? Could you, on a long-term basis, actually prevent, myocardial dysfunction? And that's something that we really are not going to have an answer to for a long time. We'll probably have boutique studies in which people start to look at the effect early in the natural history on myocardial contractility. And if we saw benefits in terms of global strain or E to A wave, acceleration time, these sorts of things, then one might be able to say we should start even before the patient develops heart failure.
Yep, the perfect answer, Professor DiFronzo. Now we come to the CKD perspectives. I think we have seen with DEPA CKD, the benefits are there. So the 2 questions which always come, earlier we used to be confident up to 45, but now we have gone even up to 30 and some even below 30 now. So between the GFR of maybe 25 to 45, how confident you are with the data from DEPA CKD? And then another question, non-proteinuric CKD, which is probably not very well studied in DEPA CKD. How do you view the data, and how confident, or what is your recommendation in using SGLT2 in non-proteinuric CKD?
Yeah. So the first question is easier to answer. So there actually are 2 papers now that have been published. One is a follow-up, the Credence study. The other is a follow-up of the DAPA data. And that even if you look at people with GFRs less than 25 to 30, because in each of these studies, about 10% of the people actually had lower GFRs. Those people benefited as much as the people who had GFRs 25 to 30 or above. So my take on this is you should be on the SGLT2 inhibitor until the time that you walk into the dialysis unit. Now, from the standpoint of heart failure, there actually are 2 studies, one with DAPA and one with EMPA, looking at people who are on dialysis in terms of treatment for heart failure. So those studies will be of great interest because it might even be that even while you're on dialysis, they may have benefit in terms of heart failure. But certainly in terms of kidney protection, all the way down to a GFR of 5 to 10 until you hand to dialysis. Now, the second question is a little bit more difficult to answer. So obviously you understand, maybe the people who are listening in don't understand, that about 15 to 20% of the people who develop overt diabetic nephropathy do so without significant proteinuria. So the question is, what do we do with those people? Well, first of all, I can tell you there's no answer to that, definitive answer to that question, because all of the people who got into these big studies, basically they all had heavy proteinuria. Now, if we now look at that 15 to 20% of people who develop advanced kidney failure going to dialysis and transplantation who do not have proteinuria, the pathophysiologic mechanisms that are involved seem to be very similar. The problem is, if you have such a patient who have diabetes and they have a GFR of, say, 35 or 40, and they don't have proteinuria, you first have to make the diagnosis of diabetic nephropathy. That requires a biopsy. You need to make sure you're not dealing with some other type of non-diabetic kidney disease. So now you do the biopsy and the person turns out to have diabetic nephropathy. I would say that at this point, even though we don't have a definitive study, that in addition to the ACEs and the ARBs, I would put the person on the SGLT2 inhibitor. And of course, I would follow that person very carefully. But we don't have a definitive study to directly answer the question that you asked. And it's a study that should be done. But of course, it's very difficult, even in a large number of centers, to accumulate, enough of these patients and to study them for 3 or 4 or 5 years to get a definitive answer. So we may never get a definitive answer to your question, but I suspect that the benefit would be there, just as we see in people with heavy proteinuria.
Yeah. So Professor DiFronzo, let's come to some diabetes data now. I think we earlier used to use them in obese patient who had some atherosclerotic CV disease, and then we thought that not everyone will have ASCVD, so even in a high risk patient we should use them. So now what the questions are coming up with latest data coming that in a controlled diabetic, so you suppose do not have an SGLT2 currently, but and the patient is controlled but has all the risk factors for CV renal disease. So in a controlled diabetic, how do you approach switching over to an SGLT2 and down titrating other therapies? And then if the patient is an elderly who is above 65, which was probably a relative contraindication a few years back, now how what is the latest guidance you would like to give in controlled diabetic as well as an elderly?
So another good and complicated question. So I can start off by saying, if they're on a sulfonylurea, that's easy. Get rid of the sulfonylurea. All that is going to do is cause trouble. So sulfonylurea is really not giving you any cardiovascular protective effect, and they have a very high incidence of hypoglycemia. So in elderly fragile people, this is not a drug that should be on board. So if I'm going to add the SGLT2 inhibitor and they're on a sulfonylurea, that's the first one to go. Now, the question is, what other drugs are they on, okay? And why are you adding the drug? So if they're inadequately controlled in terms of the A1C, then you could just add the drug. That's not a problem. Now, if they're on metformin or pioglitazone or a GLP-1 receptor agonist, and they're maximally controlled, then you're asking the question, and there's no answer to this, am I going to get cardiovascular protection by adding the SGLT2 inhibitor? And my answer to that question would be, almost a surety, yes, particularly for heart failure. So heart failure is very difficult to treat. So if I had patients on maximal anti-hyperglycemic therapy and they had heart failure was still a problem, you can add the SGLT2 inhibitor because it's not going to cause hypoglycemia as long as they're not on insulin or a sulfonylurea. And the SGLT2 inhibitors, as I've shown you, are very effective in decreasing hospitalization for heart failure. So I think you could just add the drug without having to worry about cutting back any of the other medications, even if they're well controlled. And here now you're simply treating for the cardioprotective effect. You're not treating to lower the glucose. So this issue of not having to worry about hypoglycemia, I think, is really very important because you can just use it as any other drug. The cardiologist can say, hey, this is my drug. This is my drug to treat heart failure. I don't care about what you endocrinologists are doing. And the nephrologist can say, hey, you guys, I don't really care. I'm going to treat the kidney disease and I don't have to worry about hypoglycemia. So that's one of the great beauties of this SGLT2 class of drugs.
Yeah, I have one question, Dr. Ralph.
Yeah.
Hello,
Hi.
Dr. Vasi. Hello, yes. So the question is, the post-bariatric surgery, metabolic surgery, we get some of the patients who get relapse of diabetes. And we don't have any guideline. Is there should be a guideline that they should be treated differently, or is it the same way the treatment, what we are treating for a type 2 diabetes? A post-bariatric surgery after 3 years or 5 years. So I mean, is it the GLP-1 should be given them first choice because they are, or the metformin is still be the first choice for them? Is it the SGLT2 should be added because that is to be added, definitely. So we try to treat these patients with GLP-1 and SGLT2 because they again regain the weight and they again got the diabetes because of that. But is there any guideline or how you deal with these patients?
So Dr. Shashank and I have had this discussion before. Amazingly, there's really not a good study to look at this. And we've talked about doing a multi-center trial. So just because you've had the bypass surgery doesn't mean that some of these complications are not going to come back and that you're going to lose control. So what is the best therapy after the bypass surgery? So should all of these people go on some kind of anti-diabetic agent you can't just assume that the bypass surgery is going to cure everything. Okay. So that's one issue. The second issue is, now, let's say you decide you're not going to put the person after the bypass surgery on any medication, and you're going to wait, as you said, 3 or 4 or 5 years. Well, what happens if the weight gain comes back, if the diabetes comes back? What is the best therapy? That's a study that should be done. And there really is no really good study looking at this. So if you ask me what I would do, I would treat this person in exactly the same way as I would treat the person who has type 2 diabetes. So what are my favorite drugs? They're the big 4. But metformin is at the bottom of my big 4. So I would say GLP-1 receptor agonist would be at the top of my list, SGLT2 inhibitors, and I haven't talked about pioglitazone, but you know, if you start to regain weight, for sure, you're becoming severely insulin resistant. And the only drug that really is an insulin sensitizing drug is pioglitazone. So to me, that also would be a reasonable choice. And I know people say, well, if you go on pioglitazone, you may stimulate the appetite and they gain weight. So there's a big paradox with pioglitazone. So the more weight you gain with pioglitazone, the greater the drop in A1C. The more weight you gain, the greater the improvement in insulin sensitivity. The more weight you gain, the greater the improvement of beta cell function. And interestingly, if you go to the proactive study with pioglitazone, there was only one parameter that predicted that you weren't going to die. What was the parameter? Weight gain. So I like to joke and say, look, would you rather be fat and alive or lean and dead? You know, you can have your choice. So people are afraid to use pioglitazone, particularly in this population, because of, quote, weight gain. The weight gain is a cosmetic issue. As we heard earlier from one of our speakers, cosmetic in your appearance actually is an important factor in terms of long-term weight maintenance. But it's a cosmetic issue. It is not a metabolic issue. So I would treat the person in the exact same way that I treat people with type 2 diabetes who've not undergone the bypass surgery. And as I said, my big 4 are GLP-1, SGLT2, pioglitazone, metformin.
Thank you, sir.
Thank you, sir. Satisfactory answer, and I think that I look forward to maybe another study which will be my honor and privilege.
All right.
Any other questions, Dr.
Yeah,
Harsh?
we had a question which is, Professor DiFronzo,
yeah.
You published a lot of studies on the mechanism of SGLT2 benefits. So now with DEPA-HF, DEPA-CKD also showing benefits in non-diabetic etiologies, and also we see the sugar control and BP and weight reduction do not matter a lot. So now what do you think should be our line of thought for the mechanisms, and what should be the research ideas which we should have?
Yeah, it's very clear that the benefit in non-diabetics is virtually identical to the benefit in diabetics with the SGLT2 inhibitors in terms of prevention of diabetic kidney disease. And the mechanisms people don't understand, but the mechanisms are basically the same. Tubular glomerular imbalance, podocyte injury, these mechanisms are playing a very important role in the non-diabetic as well as in the diabetic. So I've written, if you would like to review all of this, a very extensive review. It's online right now in Nature Nephrology reviews that will take you through this. And I think you'll appreciate that the mechanisms in the diabetic and the non-diabetic are basically the same. Of course, in the non-diabetic, it's not glucose control, it's all the other things. But the mechanisms by which the SGLT2 inhibitors are working are the same in both groups.
Thanks, Professor.
Brilliant. Brilliant answers. Brilliant session, sir. This will be live on YouTube for everyone to watch. Thank you so much. We made a very early start of the day for you. Have a good day. That's very kind of you to be available at such a time. I will contact you after an hour and a half after this session is over again. But special thanks from all of us. This is Indian greetings now. Thank you so much, sir.
Okay, my pleasure. It's great to be with you, even though we're a long way apart. Hopefully this COVID, plague will get under control. And next time we do this, I can come to India directly rather than doing it virtually.
Our pleasure. We'll be best host. Thank you,
Okay.
sir. Good
I'm
day.
going to sign off at this point and go back to sleep, to be honest.
Thank
All
you.
right.
Thank you.
Good night or good morning, wherever you are.
Yes, yes, yes.
Okay. Bye-bye.
Thank you, sir. Hardik? Hardik?
Sir.
Can we have Dr. Salda? Can I call him? Is his slide ready? Hardik, can you hear me?
Yes, sir. Doctor?
Dr. Dilip Salda's slide.
Yes, yes. Ready. Slide is ready, sir.
Should I call him?
Yes, sir.
Just give me a minute. So we have a felicitation. We'll interrupt for a minute. Let me just try calling him. सर बिझी आहे बरं किती वेळात बर 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 तुम्ही फ्री झाले की फोन करा सर मग लगेच तुम्हाला मी लगेच लाईव्ह घेतो हो सर हो सर हो सर ओके okay so he will call us and then we have a felicitation from Dr. Sarda. He has been instrumental in helping us get the CME credit points. So let us go to the next presentation now. And if we get delayed, then we will not delay Dr. Arya Sharma. He is also ready. Another great speaker from Canada. He is at 6:55. We'll try and finish our presentation before that. I'll share my screen. Can you see it?
Yes, sir. Put it on slideshow mode.
I'm just trying that. Yes. Is it better now?
Yes, sir.
Yes. So good evening, everyone. I'm going to talk about some novel procedures in bariatric surgery. Before that, let me just take you through some of the slides, how the evolution of bariatric surgery happened. Initially, it was only thought to be for weight loss. Then the thought process came treatment of type 2 diabetes, the treatment of metabolic syndrome, then the benefits on long-term cardiovascular and renal protection, like how we heard from Dr. Ralph, treatment of NASH, and this is how metabolic surgery for diabetes started progressing and started going ahead. And the best recognition was the IRDA and the government accepting obesity as a disease. Now it is covered under insurance, cashless insurance, and that's a boon. Though many deserving can avail this benefit and then get treated. Now, before going to this, I'm going to present an interesting fact. In the same patient, you can see here, if you feed through the joint between esophagus and stomach of the gastric bypass, patient is euglycemic. And in the same patient, simultaneously, if you feed through a tube in the remnant stomach, that is through a gastrotomy, patient behaves as diabetes. This shows that the GI structural alterations have extreme role in reversing diabetes, and this is the best example. That is why I said there were some fundamental observations that the weight resolution of diabetes occurs within minutes, hours to days before even any weight loss happens. That means there are many weight independent factors which are responsible for reversal of diabetes, and the weight loss seems to result from regulation of appetite and food intake through a central action and not by reduction in this size. This was the very old operation jejunal bypass, and it showed that it increased GLP-1, GLP-2 with excellent effects on insulin secretion, food intake, and intestinal growth. This operation was abandoned because of the side effects, and the newer procedures came in. This is one patient with example which I'll give you. 300 kg lady came down to 85, and in two-stage procedure shall be won the India Book and World Book of Records. But There are different types of procedures on the stomach, intestine, and always the apprehension is side effects, risk, nutritional complications, and exclusion from endoscopy. And I'm going to present a simple procedure where the stomach is partly connected to the intestine, so the food can go through the duodenum and through the intestine as well. Two outlets for the stomach, no part of the intestine is bypassed. All hormonal mechanisms are still present because ghrelin is reduced. Food reaches last part of ileum very fast and you have incretin mimetic effect, minimal or no malabsorption. There is preserved endoscopic access to almost all parts of intestine. Excellent published results, technically easier, easy to revise, loop procedure much easier, whole of the small bowel function is used. So apprehensions in the minds of physicians about side effects, nutritional effects, ease, risk can be minimized. This is a diagrammatic presentation, but the benefit is easier, safer, no bypass small bowel segment. So there is absorption of nutrients and simultaneously there is stimulation of the neuroendocrine system to improve the metabolism. So there are these are distinct benefits, and some such newer procedures can probably be revolutionary and they preserve the sleeve size, prevent sleeve dilatation, food passage and absorption through the entire digestive system, minimizes the need for nutritional supplements, and the endoscopic access is preserved. 5-year results of this procedure have excellent result equivalent to any other standard bariatric procedures. Preliminary reports of 8 years state that these rates have been preserved even at the same level. That means 8-year follow-up has been good. And I believe those who have this apprehension, this reversible, simple procedure can prevent all other nutritional complications. This design is promising, but we need more results from Asian countries. Challenges of selective divergence still are unknown, and more research probably needs to be done on this. But the science is evolving, and with this insurance reimbursed recognition of a disease, there could be an era where there would be procedures with minimal side effects, minimal nutritional effects, but strong hormonal effects, improving metabolism, reversing diabetes, and stabilizing and increasing the weight loss. Thank you. I would rather save my time and keep it open so that we can have Dr. Sharma in time. This is 6:28. So if there are any questions, I'll keep it open. Dr. Kiwalkar has joined. Thank you, sir, for joining. We will have you to moderate Dr. Arya Sharma's session very soon. So, Hardik, we can, if there are any questions, I'm here to answer, or we can go to the next presentation and maybe get Dr. Arya Sharma on time. I think we can go to the next presentation.
Hello. Good evening, friends. Thank you, Dr. Shashank, for this opportunity. We are going to have Dr. Arya Sharma, who is MD DSc, a professor of medicine and past chair in obesity research and management at the University of.
Arya live?
No, sir. Dr. Arya is not there.
No, then we should wait. I think maybe, Sir Kiwalkar, sir, we'll have one more presentation in between so that Dr. Arya Sharma will join exactly at 6:55. Please be with us and moderate that session. Yeah. Can we have Dr. Poonam Shah's slide and her presentation? So let me introduce her. She's my wife itself, but let the introduction slide be there. She's the founder of LOC with me, Joint Secretary of ARO, Ex-Integrated Health Committee of the International Federation for Surgery of Obesity. More than 12 publications in international journals. She's been one of the co-investigators where we won the Vivian Fonseca Scholar Award from ADA. She has received late Anandibai Joshi Award, and she is the first bariatric physician in India who has dedicated herself to bariatric practice and bariatric medicine in turn. Dr. Poonam, please. An interesting topic on whether keto diet can work after bariatric surgery.
Can you see my presentation?
No, no, ma'am. No.
Now?
No, ma'am.
Aditi? Okay, then you can run from your side.
Yes, ma'am. Yes, ma'am. Just a second.
Okay. We have Dr. Deshmukh sir also online. He's probably disconnected.
Can you see my presentation now?
Yes,
Hello?
we can see it. You can start.
Yes, yes. So actually, Dr. Shailesh Pritare couldn't be here to join us. So I'll be talking a little bit on the keto diet after bariatric surgery. And in fact, it is even my question. So you will not find at the end of the presentation that I have any specific answer for this question. Next slide, please. Next slide. Yes. So the keto diet is a diet which was popular a century ago for helping in treating epilepsy in kids. And this has now gained popularity as a weight loss diet. So it is very interesting. Next slide. Why it is important for us in a bariatric unit to know about this diet? Because post bariatric surgery, when patients have some weight loss plateaus or they have inadequate weight loss, we have patients coming to us asking about the right now two popular diets. One is about the intermittent fasting diet, and the second one is the ketogenic diet, and they think that it will help them for more weight loss. So that is why our interest in this diet. Next slide. So this is the keto diet food pyramid. As you can see, top of the pyramid, carbohydrate just about 5%, protein up to 20%, and very high fat, which up to 75%. So it is a low carb, moderate protein, and you can say moderate or you can say low protein and a very high fat diet. So that's about the keto diet. Next slide. So how does it work? When the carbohydrate is low in the diet, there is no glucose for energy. So the liver breaks down the fat which is in the diet and it makes free fatty acids and ketones. And these ketones are then used as fuel by the body. So there are potential benefits with this diet in short-term weight loss, improvement in blood sugar level, and the high fat giving a satiety. Next slide. However, there are some unwanted side effects because the carbohydrate concentration is very low and of which the fiber content will be very low. So you have the patients will suffer from constipation, can be one of the problem. Then the nausea and the vomiting related to the ketosis can give rise to dehydration. Long-term patients can have kidney stones, they can be bone loss. So this is something which is called as keto flu, and the acetone in the breath gives a sweetish smell to the breath called as the keto breath. So basically there can be some unwanted effects, and more long-term studies are needed to study the impact of this diet on long-term cardiovascular as well as the effect on the gut microflora. Next slide. And this is the nutritional pyramid post-bariatric surgery, which was proposed by Moyes et al. In 2010. If you see on the top of the pyramid, you have those things which are not recommended, and they are the high fatty foods, the processed foods, the high sugar foods, then the concentrated alcoholic beverages or the carbonated beverages. The second is those foods that we should have in minimal amount, which are the high starchy foods as well as bread. After that, you have the green leafy vegetables and fruits which are low in sugar and use of some vegetable oil like olive oil. So this is recommended more. And then in the lower step, you have the low fat meat and the low fat dairy products, you have eggs, you have the legumes. So these are the type of diet which is maximally recommended in a post-bariatric patient. And of course, the lowermost shows that the importance of physical activity, daily physical activity, daily nutritional supplements, especially for the bone health and iron, and most important is hydration. So this is the post-bariatric diet, which recommends a high protein, moderate carbohydrate, and minimum fats with a good hydration and use of micronutrient supplements. Next slide. So we know that the bariatric procedures are restrictive as well as malabsorptive with a small stomach size and longer common channel as seen in a Roux-en-Y gastric bypass or a mini gastric bypass. And second slide. Next. And you have these bariatric procedures which are totally malabsorptive, deliberately malabsorptive. These are the BPD, the biliopancreatic diversion, and the BPD-DS, the duodenal switch. If you see, the stomach size is large, the stomach pouch is large enough, but the common channel where there is food absorption is actually very, very small. So these are the challenges of the bariatric procedures. Next slide. Next. So post-bariatric surgery diet plan, as we know, varies, starts from clear liquids and we go on to solids. So in the first 6 to 2 months, the patient is mainly initially on liquids, then on semi-solids, then there are less of solid intake in the initial months. We emphasize the patients to take protein shakes. So lesser calories are consumed in the initial 6 to 8 months. And later on, the patient starts increasing the food intake. There are more solids. So gradually the calorie intake increases. Again, then there comes a challenge of protein intake. And there is a malabsorption of fat giving rise to various nutritional challenges and steatorrhea, etc. After 2 to 3 years, what happens is the intestine starts to adapt to these challenges and there will be a decrease in malabsorption. So next slide. So what will happen when we give a ketogenic diet to a bariatric surgery patient? Now, when they suggest the high fat diet, the source of the high fat is important for the patient to be able to follow, because then the patient who is actually very busy in his daily routine may just select some ready-made processed food which has a very high concentration of fat, and then the intention will be defeated. The vegetable oils which are suggested, oil, the olive oil, the avocado oil, the coconut oils. So the various oils that are suggested, they are actually quite expensive, not easily available. Then eating high fat or a volume of fat will decrease the simultaneous intake of protein and carbohydrates. So that is going to be a big challenge, because as we saw, a bariatric diet is a high protein diet requirement. The malabsorption of the procedure itself will cause some steatorrhea, the loss of that fat, and therefore the benefit of taking that high fat is lost, and there will be nutritional challenges. There is low fiber intake because of the low carbohydrate, and then this patient will have the challenge of constipation and a chronic low fiber intake. We don't know about whether there will be increased cardiovascular risk to this patient. There are more calories which are consumed, therefore which will give rise to inadequate weight loss or the problem of weight regain. The very high fat liquids can give rise to dumping, which will be very uncomfortable to the patient, and again it will not be of much benefit. The satiety and the fullness which is given by the fat will also decrease the liquid intake, which is very, very important for a bariatric patient, and this may lead to dehydration. The nausea and the vomiting induced by the ketogenic diets or by the ketosis will give rise to dehydration, and the patient is prone for vitamin B1 deficiency in the acute phase. So these are the challenges that I can think of can happen to our patient if the patient receives a ketogenic diet post bariatric surgery. Next page, next slide, please. So whether to give a ketogenic diet to a post bariatric patient is a question mark. I personally not very comfortable. Now, whether in short term it will be beneficial or not, I don't know. And long term, it doesn't appear to be very beneficial. Some people have suggested a modified ketogenic diet where the fat remains high, but the protein is also suggested as high, 75 grams, and the carbohydrates of less, that is 13 grams. But I doubt whether this is possible in our Indian diet, where protein, increasing the protein itself is a big challenge. So I leave you with this question. Next slide, please. That I don't know the answer exactly, but I am not comfortable giving a ketogenic diet to my post-bariatric patient. Thank you very much. It is open for discussion.
Thank you, Dr. Poonam. We have Dr. Arya Sharma here. Very good morning, and thank you for joining us. It's an honor to have you here. Any comment on ketogenic diet after bariatric surgery? Because the amount is small, fat doesn't get absorbed. Dr. Sharma is a researcher and he speaks very well, writes very well. So maybe his comment on this. And Dr. Kiwata sir, if you have any questions. Can you unmute yourself, Arya? Can you unmute yourself? Yes.
Yes, hello. I certainly agree with everything that has been said, and I generally do not recommend the ketogenic diets after surgery.
Perfect. Summary in one line. Dr. Kiwata sir, any questions, comments? Thank you, sir. Hardik, we can have Dr. Arya Sharma's side. Dr. Poonam, can you introduce? It's a good friend of ours, and we are privileged to have such a friend and a faculty for our MetaSurg OBENCON. Dr. Poonam, please.
Dr. Arya Sharma, he is a MD FRSBC in Professor of Medicine and past chair in Obesity Research and Management at the University of Alberta, Edmonton, Canada. He is also the clinical co-chair of the Alberta Health Services Obesity Program. He's a founder and scientific director of the Obesity Canada, a network of 10,000 obesity researchers, health professionals, and other stakeholders. He's also the past president of the Canadian Association of Bariatric Physicians and Surgeons, and his past appointments also include positions as Professor of Medicine and Canada Research Chair, Taiwan at McMaster University, Professor of Medicine at the Franzwald I don't know how to pronounce this, clinic in Berlin, and the Free University of Berlin. So his research focuses on the evidence-based prevention and management of obesity and its complication. He has authored and co-authored more than 450 scientific articles and has lectured widely on the etiology, management of obesity, and related cardiovascular disorder. So he is regularly featured as a medical expert in national and international, print media, and maintains a widely read obesity blog. So Dr. Sharma, I think so how much ever I say about you is less, and we are very happy to have you here. Welcome.
And known for Edmonton Obesity Score and also for Canadian guidelines. So I think it's going to be an eye-opener. I think we have a pre-recorded session and he's still joining us.
Dear colleagues, my name is Arya Sharma. I'm Professor of Medicine at the University of Alberta. And it's a pleasure for me to be talking to you today about the new Canadian Obesity Clinical Practice Guidelines, which were released last year. So let me just bring up my presentation for you here. Okay, here we go. So the 2020 Obesity Clinical Practice Guidelines was a joint project between Obesity Canada and the Canadian Association for Bariatric Physicians and Surgeons. It was published last year in September in the Canadian Medical Association Journal, which is the most prestigious Canadian journal. This journal gets mailed to every single physician practicing in Canada. And it turns out that despite the entire COVID problem, this was actually the #1 downloaded articles in CMHA, which really shows us that physicians have a lot of interest in the issue of obesity, as they should. Now, what I want to cover in the next few minutes is I want to talk very briefly about the rational scope and the methodology used for these guidelines. I then want to highlight some of the key previous changes from previous guidelines, because there are some important points here. And then I just want to very briefly touch on the expanding role that I see for obesity medicine in general. Now, in terms of rational scope and methodology, the last time we had guidelines in Canada was back in 2007. So that was 14 years ago. And since then, a lot of things have happened. For one, we've had the Canadian Medical Association declare obesity as a chronic disease. That was back in 2015. We have learned a lot about the impact of bias, stigma, and weight-based discrimination on our patients and access to care. And I'll talk about that very briefly. We've had an enormous expansion in our understanding of the science of obesity. We understand now much better how the body regulates its body weight. We understand a lot of the subcortical processes that are involved here, and we have certainly learned a lot about the biology of how the body protects itself against weight loss, which of course is relevant when we are trying to get our patients to lose weight in the long term. There have also been a number of advances in obesity treatments and therapies, many of which I'm sure you'll hear from or hear about throughout this meeting. And I think that we have also come to recognize that in obesity, like in many other diseases, we have to take a patient-centered care, and we have to look at outcomes beyond simply weight loss. Now, given that obesity is such a common condition affecting so many millions and millions of people, this is not a condition that can just be seen by a handful of specialists. So we have to think about the fact that this is a condition that will primarily have to be treated by the family doctor. And that is also why the family doctors or primary healthcare professionals are the target audience for these guidelines. This is not a guideline written for specialists. This is a guideline written to be practical so that every family doctor, every practicing physician who sees patients on a daily basis for whatever purpose will feel more comfortable in addressing obesity and approaching obesity. So the guideline is really intended to improve the standard of and access of care to all individuals living with obesity. Now, in terms of the key changes from previous guidelines, perhaps the most important change is the definition of obesity itself. As you all know that in the past, we have always used a body mass index based definition. The problem with body mass index, as you all know, is that it is calculated simply from height and weight, which means it is really a measure of size. It's not a measure of health. And we know that, across various ethnic populations, the relationship between BMI and health can be very different. For example, in South Asians versus Caucasians, there's a lot of difference there. But we also know that even within one ethnic community, there can be tremendous differences in the relationship between body mass index and the presence of any health issues. So, for example, you can have two people who both have BMI 35, and one of them has all kinds of health issues, fatty livers and whatnot. And the other patient or the other person at BMI 35 might actually have very few health issues or no health issues. And so we have to move beyond just a body mass index centric view of obesity. So what we've done in these new guidelines for the first time in any guideline, we have defined obesity as a prevalent, complex, progressive, relapsing chronic disease that is characterized by abnormal and excess body fat that impairs health. And the key word here is impairs health. If you do not have a health impairment that is attributable to excess weight, then you don't have obesity. Obviously, as you go to higher and higher body mass indexes, you're always going to find that people have more and more complications. But the defining characteristic of obesity is not your size. It's not your weight. It's not the number on the scale. The defining characteristic of obesity is a health impairment that is attributable to excess body fat. This doesn't mean we should forget about body mass index or waist circumference. Of course, they are useful measures because they can be used as screening tools, but they should not be used simply for the diagnosis of obesity. This has to be based rather on the presence of functional, medical, or psychosocial impairments, which are related to the presence of abnormal or excess body fat. And that means that you are going to need a clinical exam, a visit to your doctor, doing appropriate tests, to determine whether or not someone has obesity. It is not something you can do by yourself, step on the scale and decide. Now, having said that, of course, we have to remember we are talking about a chronic disease. And this means for us that obesity management should be based on the evidence-based methods of managing chronic disease, which we are all familiar with, but because we apply the same rules for chronic disease management to every other chronic disease. When you think about your patients with diabetes, your patients with heart disease, your patients with, with chronic obstructive lung disease, there are always principles of chronic disease management that we understand and we know, including patient education, self-management, regular follow-ups, self-monitoring, and all of the other, factors or techniques that we know work so well for chronic disease. We have to apply them to obesity, and we have to move beyond simply telling patients to eat less and move more, because we have a lot of data now, including data from randomized controlled trials, showing that for most patients, this approach is not effective. In fact, it can actually be detrimental to patients' health, because simply by eating and moving more, even if you manage to lose weight, the long-term success is actually quite limited. And so, we state very clearly that people who are living with obesity should have access to evidence-informed interventions, and these, of course, have to include medical nutrition therapy, physical activity, psychological interventions, pharmacotherapy, and, of course, also surgery. So having said all of that, what we present in the guidelines is a 5-step approach to obesity management, which many of you might have heard of, called the 5A step approach. And the first step here is the ask. And here we have to recognize that obesity as a chronic disease carries a lot of bias, carries a lot of stigma, and therefore it is very important that as health professionals we acknowledge the presence of bias, and we understand that this is a sensitive issue for many patients. And therefore it is very helpful and perhaps advisable to always ask patients for permission before we offer any advice on obesity or on their weight. And when we do so, we need to do this in a very unbiased manner. We have to remember that weight bias is very, very common. People living with obesity, they face substantial weight bias and stigma, and this has a direct impact on their health and well-being, as well as on their access to care. So in the guidelines, we specifically recommend that all healthcare providers should assess their own beliefs and attitudes towards people living with obesity, and think about how your attitudes, which might in many cases be negative or rather simplistic, and how these might actually influence the healthcare that you're delivering to your patient. At the same time, we should also be aware that many patients blame themselves and carry what is known as internalized weight bias, and that this presence of internalized weight bias can actually have very substantial adverse effects on their own behaviors and their own health outcomes. So we have to acknowledge and in fact assess patients for the presence of these negative feelings that they have towards themselves. The next step is assessment step. Now, in the assessment of individuals living with obesity, we obviously have to use appropriate measurements, but the goal here is to identify the root causes and drivers of obesity, to look at the complications, and also find out and assess the barriers to obesity treatment. Now, the framework that we recommend for this is called the 4 M's framework, and the 4 M's stand for mental health, where we have to, understand that any aspect of mental health is going to have an impact on body weight, whether this is knowledge, expectation, self-image, depression, anxiety disorder, attention deficit disorder, past trauma, grief. All of these factors can very substantially promote weight gain. Sometimes they can be consequences of excess weight, and in many cases they will be important barriers to weight management. So we have to assess mental health. We have to look for mechanical complications, so osteoarthritis, sleep apnea, etc. Because again, many of these complications, they can drive weight gain, they can be consequences of excess weight, and they can make weight management very difficult. Of course, we also have all of our metabolic problems. We have type 2 diabetes, dyslipidemia, hypertension. There's a long list of problems. And again, many of these problems can contribute to excess weight. They can be consequences of excess weight. And the presence of these conditions can make obesity management quite difficult and challenging. We should remember that very often the medications that we use for treating mental health or pain or metabolic disease can themselves be part of the problem, in that they promote weight gain or make losing weight very difficult for patients. So every assessment for obesity also has to include a review of all of the medications that patients are on. Finally, we have to always appreciate the importance of the social milieu in which patients are, the socioeconomic status, their education, their occupation, what is their access to food, disability, access to medication, access to surgery, access to other treatments. All of this information is required in order for me to complete an assessment of obesity and in order to come up with a treatment plan. In the next step, it's important to remember that there's no single blood test or diagnostic evaluation that you have to do in every patient. Now, we recommend in the guidelines that all evaluation should be based on presenting symptoms, on the patient's risk factor profile, and of course on your clinical index of suspicion. Now, obviously for most patients, this is going to include screening for metabolic syndrome with HbA1c levels, fasting blood sugars, cholesterol, lipid levels, etc. But there is not one test that is compulsory that you have to do in every patient. You have to use your clinical judgment in deciding which tests you want to do for a patient based on the symptoms that they're presenting, their age, their risk factors, etc. Obviously, patients at high risk of fatty liver syndrome, which includes everybody who's got type 2 diabetes, they should probably be screened with an ALT level and perhaps even an ultrasound. Now, having said that, as many of you know, and as I've already mentioned, the body mass index itself is not a very good predictor of outcome. And so, as many of you might have heard by now, we have the Edmonton Obesity Staging System where we classify patients based on the presence of comorbidities. And in population studies, we have shown that this is a much better predictor of long-term survival or all-cause mortality when compared to body mass index. And our clinical decisions and should really be based on more than just BMI. And so we strongly believe and recommend in the guidelines that we use the Edmonton Obesity Staging System, which now has a lot of evidence behind it, to support clinical decision making in terms of which patient needs treatment and what treatment should be applied. So once you've done the assessment, we come to step 3, which is now giving the advice to the patient. Here we discuss the different treatment options. We talk about whatever option should be there. Obviously, we want to talk about medical nutrition therapy and physical activity, but we have to remember that for most patients, you're also going to need psychological interventions, probably pharmacological interventions if the patient has access, and then of course bariatric surgery. And we should not look at these treatments as being, first do one, then do the next, then do the other one, but we have to look at them as complementary. These can be combined. You can have a patient who changes their diet, does physical activity, has psychological intervention, takes a medication, and in spite of everything might still need bariatric surgery. So we have to look at combining all of these treatments as appropriate, always keeping in mind that our goal here is not to maximize weight loss, but rather to get the maximum improvement in health. The step 4 is then to agree with your patient on the treatment pathway, and ultimately, because this is a chronic disease, you have to assist your patient on the pathway. This is a lifelong pathway. We don't have a cure for obesity, but it can be managed, but this requires long-term management. So having said that, the guidelines point out that there's an increasing scope of obesity medicine. The guidelines are very comprehensive. There's 270 printed pages. There are 80 evidence-based recommendations touching on many, many aspects of obesity management, including pregnancies and menopause and and mental health and pre-surgical and post-surgical management of patients. So, I recommend that you take the time, if you're interested in the topic, and download the guidelines, or at least look at the guidelines. They are freely available at Obesity Canada. And if you just Google Obesity Guidelines Canada, I'm sure you will find the page, and I hope that you will take the time to review these guidelines. So thank you very much for your attention. I'm sorry I cannot be there with you in India right now. But hopefully I will be able to travel to India soon. And I hope you have a great rest of the conference. So thank you again for your attention.
Delhi, I think.
Hardik, thank you, Dr. Sharma. Excellent presentation as usual. Hardik, can I have my video started? Yes. Yeah. So I have one question for you. These Canadian guidelines, how seriously are they followed in Canada based on whatever thought process, and what can we do to make our clinicians in India follow similar thought process?
Well, there's always an issue of getting physicians to follow guidelines, as you know. But the guidelines were very well received. They have received a lot of attention, both in Canada and internationally. As I mentioned in my talk, it was the most downloaded article of the Canadian Medical Association Journal this year. So a lot of people have seen the guidelines. I think what we are seeing is slowly a growing understanding of the complexity of obesity and the fact that we have to, that it should actually be part of every doctor's job to also manage obesity. And so we, of course, hope that in the next, months and years, as doctors become more comfortable with managing obesity, these guidelines, of course, will have their impact.
Thank you. Can I request you for a thing? Maybe I will request Dr. Kivalkar and Dr. Poonam to present two case scenarios, one extreme, one borderline, and have your opinion so you can let us know how you think about those cases based on those guidelines. Hardik, can we share those two slides?
Which slide?
The case presentation, case discussion.
Aditine पाठवलेलं.
Anyway, Asians need these Canadian guidelines more than probably Canadians, what I feel. Do you agree to this?
Well, the guidelines are freely available. So, anybody is welcome to take a look and to download the guidelines and to look at the guidelines because they are intended for for primary practice. So it's not for a specialist, but for somebody who's, doing family medicine, for example.
Hardik, can you find those slides easily or should I discuss them? Either way is okay.
Sir, in Poonam madam presentation or?
Aditi had sent you two slides for.
No, we can't receive any two slides about regarding case.
Okay, so let me put it this way. Maybe a patient, maybe middle-aged lady with a BMI of 34, maybe diabetes of 5 years duration, central obesity, waist circumference of 112, and comes to a clinician. How should a thought process be in presence of maybe a better pharmacotherapy available? But the risk factors are high, waist circumference, typical Indian lady.
Yeah. So before we go to the best, my first question in any patient is always: are they currently weight stable, or is the weight going up? If the weight is going up, we have to see what are the reasons for the weight going up. So there we are looking at the 4Ms. So we have to see, does she have any stressors? Does she have any mental health issues like maybe depression, anxiety, anything else going on that is causing her to gain weight? Because the first step in obesity management is to stop the weight gain. So to stop the weight gain, I have to understand what is driving the weight. Now, once she's weight stable, or if she's currently been weight stable for some time, then the next question is, of course, what is the complications that she has? And as you said, she's a typical Indian lady, and she has, of course, all the metabolic risk factors. So clearly, there's an indication for obesity treatment. If you apply the Edmonton obesity staging system, you would say she has stage 2. So stage 2, definitely she needs some form of obesity treatment. So if in my assessment, I find that there may be some psychological issues, behavior issues, etc., then of course, I would, probably want to have some conversation with her about that. And if appropriate, we would get a psychologist involved. But if not, I personally, in my practice, if she has access to medication, I would certainly, discuss medication with her as first step. So, the medication we have in Canada is we have the liraglutide, as 3 milligrams. You can start at a lower dose, of course, and then see if she responds, and then you can increase to 3 milligrams. And a lot of patients benefit from that. We also use in Canada, we also have the fixed combination between naltrexone and bupropion. That combination is also quite helpful, especially in people who have a lot of emotional eating cravings, some patients who have history of depression. That's also a useful medication. So those would be my steps. Obviously, if she has sleep apnea, the question is she using her machine? Does she have a machine? Is she using it? Because we know that having good sleep is very important. And those would be my initial thoughts.
Okay, perfect. I have a question for you. Now, all ADA, everyone is looking at maybe all the standardization based on long-term cardiorenal protection, and all guidelines just from glycemia have gone there.
Sure.
So such a lady has uncontrolled diabetes, and we heard from many that maybe unknown baseline heart disease would still be there. She has central obesity, and the best long-term cardiorenal protection is seen from a bariatric procedure. So how would you weigh beginning of pharmacotherapy for this patient against bariatric surgery for this patient? How should we think?
Well, obviously, uh, we know that bariatric surgery for this type of patient can lead to remission of diabetes. It is not everybody. She has only had it for 5 years, so there's a good chance that she will get remission at least for a few years, maybe, depending on what the result of the operation is. So it is certainly on the radar. But we also have. But if she's not agreeing to the operation, or if she's not interested in the operation, then of course we also have evidence now showing that both the SGLT2 inhibitors can offer renal protection and improvement, but also of course the GLP-1 analogs, which and both compounds together can of course also help with some weight loss. Obviously not as much as bariatric surgery, but you can get a 10-15% weight loss with those medications. And so that would be the alternative to bariatric surgery.
Yes. So the best bariatric physician. Now we have a case here, BMI 48, uncontrolled diabetes on OHS, sleep apnea. The creatinine is rising. There is NASH of grade 3. And there is apprehension in the mind of a physician of increasing creatinine, or what would happen to the kidneys, or maybe malabsorption. Would it worsen the liver disease or kidney disease? So as a bariatric physician in Canada, how would you treat this patient?
Well, you would certainly consider this patient for bariatric surgeries. She has a very high body mass index. There's not a lot of other treatments for that. The creatinine, 2 is not so high. It might be in the Indian context because you have a lot of sarcopenic obesity in India, and people have low lean body mass, and so even a creatinine of 2 might actually show that there's quite a significant impairment of renal function. The fatty liver grade 3, I don't know how this was determined, whether this was a biopsy or not. Obviously, once you have advanced fibrosis in the liver, the reversibility of those changes with weight loss may not be 100%. But I would certainly advocate for surgery. She was going to need some very tight management after surgery, because of course the dangers of dehydration. If she's not eating, the blood urea will go up, and then and if you have a combination of blood urea going up and she's getting dehydrated, maybe she's having some vomiting, maybe she has some dumping syndrome or any other problem, then she's of course she will have to be managed. Fluid intake will have to be managed very carefully, otherwise she might end up on dialysis, and we don't want that. So that would be my concern, but I think it can be managed. I mean, obviously she has to be warned about it, and she has to be followed very closely post-surgery.
We just wanted to hear from the best bariatric physician. So here's his opinion. Obviously, I agree with you. Very well answered. I have 2 more questions. We don't have bupropion naltrexone combination available in India, but we have isolated bupropion available. How effective would only use of single drug bupropion for treatment of obesity?
Yeah, bupropion itself is not very effective for weight loss. It can reduce the cravings. If the patient has some depression, it can be very helpful. But alone, it does not have a big impact on weight loss. It is only the combination of bupropion and naltrexone which gives you that weight loss effect. So bupropion alone, I would only use if the patient has depression. I would use it. Otherwise, if I'm looking for weight loss, I don't know if naltrexone is freely available in India or not. But you can of course do an open combination of naltrexone and bupropion.
Okay. Another question. We have topiramate available among topiramate and phentermine, and we have bupropion available. Of course, there is no data, but is it possible to use topiramate and bupropion? Because that's not an approved combination, but that is what is available in India.
Yeah, I have no experience with that combination. Topiramate, when you use it alone, first of all, not everybody loses weight. And also the dose when you use it alone has to be higher. The advantage of using the combination of phentermine and topiramate, if you can combine them, you can use lower doses of both medications. And actually, if the patient tolerates it, you can get quite significant weight loss. So I don't know about the combining of combining bupropion and topiramate. I don't know. Maybe you have some experience there, but phentermine and topiramate, that combination, as you know, is available as a fixed combination at least in the US.
And for weight loss in a patient with diabetes, can we combine GLP-1RA, SGLT2 inhibitors, and one of these approved medications? Because combination is nowhere recommended as a guideline.
Well, of course, if you're using liraglutide, that is already a GLP-1 analog, right? So there's so obviously if you're giving liraglutide, then you don't give another GLP-1 because already there is a GLP-1. But you can of course combine SGLT2s, and if the patient needs insulin, basal insulin or any kind of insulin, that's also okay. I personally try to avoid the sulfonylureas because they promote weight gain, so I try to stay away from that. But there is no problem combining SGLT2 and GLP-1.
I think I'm satisfied. Wonderful presentation. I keep it open for any more questions. Sarda sir has joined. So very good. Sarda sir, Dr. Sharma from Canada is here. Dr. Dilip Sarda has been a supporter for all doctors in our entire state, and he has helped us get to CME credit points. So he is listening to you.
Thank you very much, Shashank. Thank you very much.
Please stay after this presentation. We have a small felicitation for you, virtual, of course.
I see. Okay.
So, Dr. Sharma, thank you so much.
Okay.
Have a great day. Thank you for starting your day early for us. And it's been an honor and privilege for us to have you here. And about the email, please forward that email again, and I'll be in touch with you about that interesting study.
Sure. Thank you.
Thank you. Thank you.
Bye.
Stay safe. Yeah. Thank you, Bansi. So, Hardik, can we have Dr. Sarda's slide and felicitation? So, Dr. Sarda sir is a life member of IMA. He's a past president IMA Maharashtra State, chairman of Pune Nagar Road Doctors Association, president Medicine Association, president Sports Medicine Association, secretary Indian Academy of Pediatrics, secretary Indian Association of Occupational Health, convener of Child Abuse, Neglect and Child Labor West Zone India, president IMA Pune branch, joint secretary IMA Maharashtra State, president Lions Club, executive committee member, social security scheme of IMA Maharashtra, executive committee member, Maharashtra Medical Council, president Pune Cycle Pratishthan, almost everywhere, all fields across. One-stop support for all doctors in Maharashtra, and we are really blessed to have his blessing and support all the time. Sir, thank you so much for all your help and support all this time. We cannot invite you actually, but this is a virtual felicitation.
I understand. Shashank, I understand. Thank you very much. And my best wishes for MetaSurge and your team.
Thank you, sir. Thank you so much, sir. Hardik. So we have many foreign faculties and everyone who presented today.
Wonderful, great.
Thank you, sir.
Dr. Hardik. And I think we are finishing it dot on time. Everything went on schedule. For all those who are attending, all these lectures will be available on YouTube and they can still attend it.
So see you all tomorrow at 4 p.m. again.
Poonam, just a minute.
Yes, sir. Yes, sir, I am here. Sir. You are muted. You are muted.
Just a bouquet or something for Sarda sir's felicitation, apart from whatever I said and my greetings to you. People are there for 4 hours and they are still online. I see Dr. Bansi Sabu still there. Sir, now cycling, everything must be on a hold because of COVID, right?
No, it is going on. Every
It is
day in
going
the
on?
morning, I go at 6 o'clock.
Oh my God. My
Cycling,
God.
walking, and everything is going on. And how many delegates today?
Sir, about 400 registrations.
Congratulations,
I have to
Shashank and
thank you,
team.
sir.
Congratulations.
Thank
Great,
you, sir.
great.
Thank
These are
you, sir. And we
all
have,
over Maharashtra,
sir, all over India. All over
all over
India.
India. Oh,
And because the International Federation also endorsed it, a mail has gone worldwide. So some international delegates also will join only for certain lectures.
wonderful.
And Dr. Hardik is a physician from Ahmedabad. He is hosting it. He has emailed to everyone very promptly. Hardik, congratulations and thank you for wonderful job for first 2 days.
Thank you, sir.
We are making Dr. Sarda wait, Hardik. आता काहीच नाही ना सर तुमचे इमर्जन्सी संपली ना that patient is okay, you are in emergency, sir was in
Okay.
emergency when I called emergency.
Fine, absolutely fine.
Hardik, is there a technical problem or is it going to take time?
Just 10 seconds more.
Okay, thank you. Total video back. Sir, thank you so much. Thank you so much for all your support, all your help from all
Yes.
of us, organizers, speakers, delegates, and entire LOC team. Thank you, sir.
Thank you very much, Shashank and Poonam. Thank you and all the best to your team.
Thank you, sir.
Thank you, sir. We can conclude the day, Poonam.
Yes.
Poonam.
Thank you, everybody, for being online for such a long time. Thank you, Dr. Sada, for taking time and joining in. Thank you, Dr. Bansi, and all the friends and colleagues who are here. And see you all tomorrow at 4 p.m. with more interesting surgical topics. Thank you all.
Yes.
Thank you very much.
Thank you, sir. Thank you. Logging out.